I'd just like to say firstly, welcome to the Allergy and Immunology Education Day. I'm Lana Rosenfield. I am the chair of the Manitoba Allergy Society. Before we begin, I would like to acknowledge that the University of Manitoba campuses are located on original lands of Anishinaabe, Anishinuak, Dakota, Oite, and Dene, and on the national home of the Red River Métis. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. For today's presentation, as you know, we'll be using Slido, so slido.com, #allergy to record your attendance and collect credit hours, and will be also used as the audience response system. Please complete the speaker's evaluations as well as the overall evaluation at the end of the day. We appreciate your feedback. It is very important for planning and organizing future events. For today's Allergy and Immunology Half Day, we are going to be doing 4 talks: food allergy, immunodeficiency of primary care, Urticaria-Angioedema, and allergic rhinitis. All of these talks were developed by the Canadian Society of Allergy and Immunology for an allergy and immunology school that was targeted for primary care. So just want to thank them for allowing us to use these presentations and accrediting this event today. Our first session is by Dr. Elissa Abrams on food allergy. Dr. Abrams is an associate professor at the University of Manitoba and holds an adjunct appointment at UBC and the University of Colorado. She is president of the allergy section of the Canadian Pediatric Society and on the board of the Canadian Society of Allergy and Clinical Immunology, and is a member of the Joint Task Force on Practice Parameters, as well as the Global Burden of Disease Unit at the University of Washington. She has a Master of Public Health from Johns Hopkins University and is a medical advisor at Public Health Agency of Canada within the National Advisory Committee on Immunization. She had published over 250 articles in peer-reviewed journals and co-authored over 15 allergy practice guidelines through the CPS and CSACI. Thank you very much, Dr. Abrams, for coming today, and she can restart her presentation.
I will restart. Lana, will you just let me know that you can see this okay?
Looks good.
Okay, thank you. Thanks everyone for attending. Sorry about seeing slides on mute for several minutes. Hopefully this will work better. Lana's already told you that this is accredited. These are my disclosures. You've already heard about them. By the end of the program, you will be able to know more about allergy testing and how diagnostic they are for food allergy, describe the evidence on how to prevent food allergy, identify resources that can be used in your practice, know that management of food allergy is widening, and understand how a referral to an allergist can help your patients with diagnosis, management, and assessment of resolution of food allergies. So we'll start with the family case. This is a 3.5-year-old boy who is new to your practice. He has a peanut allergy. So the questions are, is he allergic? How is he treated and when to refer? Mom is pregnant. She wants to know if she can reduce the chance of peanut allergy in a new baby. This child first ate peanut at age 3 years. After 1 bite, he had hives and wheeze. He went to the emergency department. He got epinephrine, prescribed an auto-injector. Mom is also breastfeeding. Is pregnant. Sorry, she wants to know if she should be eating peanuts in pregnancy, breastfeeding, and when to introduce peanut to the new baby. So we're going to talk about food allergy today, but food allergy falls within a much broader range of food intolerances, which would include things like lactose intolerance. And then within that, immune-mediated food reactions, which includes not just food allergy, but other immune-mediated reactions, like, for example, celiac disease. We're going to focus on IgE-mediated allergic reactions, which are food allergies that can cause anaphylaxis, within this broader category of immune-mediated food reactions. There is a spectrum of food allergy disorders by pathophysiology. Many of us are most familiar with the IgE-mediated grouping, which is immediate reactions with food ingestion. So things like anaphylaxis, urticaria, also oral allergy syndrome, where you are allergic to pollens, and you can react to proteins that are similar to pollens that are in fruits and vegetables. So especially during pollen season, you eat a specific, for example, pitted fruit, and you'll have some symptoms in your mouth. It tends to be much milder than anaphylaxis. There's also mixed IgE cell-mediated, and included in that is atopic dermatitis or eczema, although we're increasingly understanding that this is largely a genetic condition and is not a manifestation of food allergy, although it predisposes to food allergy. And then there's non-IgE mediated. The two that we see most commonly here are food protein-induced enterocolitis syndrome, or FPIES. This is most common in young children where they eat a food such as oat or cow's milk products, and a few hours later have profuse vomiting, lethargy, pallor. It's non-IgE mediated, but in 10 to 15% of the time, there is some IgE mediated contribution to it. And allergic proctocolitis, this is in infancy where infants have mucousy, bloody poops. It was formerly sort of known as cow's milk protein allergy. There is a few others on this list that are much less common. In terms of the clinical features of IgE-mediated allergy, by far the most common is skin, hives, swelling, followed by respiratory symptoms, shortness of breath, wheeze, cough, followed by gastrointestinal symptoms, severe abdominal pain, vomiting, diarrhea, followed by CNS and cardiovascular symptoms like syncope. These are very, very uncommon, the CNS or cardiovascular symptoms in children. In infants, you can have irritability instead. A big thing about an IgE-mediated reaction is that it is quick in onset. We say 2 to 4 hours after being exposed to an allergen, but practically it's within minutes usually, and it resolves within hours. So if you're seeing symptoms that are persisting for days and days, or have happened after a prolonged period, for example, a child stopped amoxicillin and 7 or 8 days later had a rash, it is very unlikely to be IgE mediated. In terms of the most common food allergies in Canada, this is changing a little bit. So milk and egg, yes, for sure. Nuts, yes. Seafood, for sure. Wheat, we're increasingly seeing less and less IgE-mediated allergies to wheat. We are seeing wheat and other grains much more commonly causing non-IgE-mediated reactions like FPIES. Soy, too, it's just much less common than we used to see. And if we see it, it tends to be more with, for example, proctocolitis. Seeds are more and more common as allergens. Legumes are more and more common as allergens as well. This was a study done about 6 years ago, looking at the prevalence of probable food allergy in Canada based on self-report. And you can see the numbers differ between kids and adults, but nuts, seafood, milk, and eggs are the most common. Wheat and soy, less common as well. It's also important to know that some allergies like milk and egg, wheat and soy allergy tend to go away. As if they develop in childhood, they tend to go away over time. There's an 80% rate of resolution for those. For nut allergy, it's much less common. For peanut, it's about 30%. For tree nuts, it's about 9%. For seafood, it's really interesting. We used to think that seafood allergy did not go away, but there's been a few new studies that have shown that there's almost a 50% chance of outgrowing a seafood allergy over time. Now, this slide is meant to illustrate an important point, but it needs to be taken into context. So we know that anaphylaxis can be fatal, and that the best way to prevent a fatality is to use epinephrine quickly. And so it's always important to make sure if there's a food allergic patient in your practice that they're reading labels, that they have their auto injector with them, that they're comfortable using it if there is an allergic reaction, because we know that's the best way to prevent a severe outcome. But the actual risk of fatality due to anaphylaxis is about 1 in 10 million, which you can see in this graph is about equivalent to death due to lightning. It is 100-fold less common than death due to fire or death due to murder in Europe, and 1,000-fold less common than death due to murder in the United States. And the reason this slide has some importance is because one of the biggest morbidities in food allergy is its impact on quality of life. I work in pediatrics, so I always think about the child, but for the child and their family, the sense that, you know, at any time there can be a fatality if there's an accidental exposure. That can happen, but thankfully it's actually exceptionally rare. If we're looking at how to reduce fatality, all the studies that have looked at fatality have shown the biggest risk factor to be not using epinephrine quickly. So if there is an allergic reaction, the best way to prevent a severe outcome is to use the auto injector quickly. I will have families say to me, well, when do I know when to use the auto injector versus not? The answer there is that it is always safe to use it. If you're ever debating about using it, I would say use it. Definitely if there are two systems involved, like skin plus something else. If it's skin alone, I say it's never wrong to use the auto-injector. If it's skin and it's systemic, like spreading all over the body, I would. But even if it's a milder skin reaction, if there are other factors at play, for example, you're in a remote location, you're traveling, you're far from a hospital, it is never wrong to use the auto-injector, and it is always safe. Another risk factor for death due to anaphylaxis is uncontrolled asthma. So there is always a big focus in children or adults with food allergy to make sure that the asthma is diagnosed if it's present, and that asthma is well controlled if it's present, because if it's uncontrolled, you can have more severe anaphylaxis. Moving on to food allergy diagnosis. What is the gold standard to diagnose food allergy? Compatible symptoms upon an oral food challenge, IgE testing, IgG testing, or skin testing. So the answer is an oral food challenge. This is when a child or an adult will come into an allergy office. They will eat incremental amounts of a food, and they'll be observed to see if there is an allergic reaction. We don't do this all the time. We don't do this if there is a clear history and compatible allergy testing, but it is the gold standard, and it can help us if the history is unclear. We can also use this over time, for example, if skin tests are getting smaller, to diagnose that a food allergy has resolved. Now, IgE testing, that's either skin testing in the allergy office or blood testing, support a diagnosis, but does not make a diagnosis in the absence of a clear clinical history. There is a huge false positive on allergy testing, up to 40%, especially in kids that have, or adults that have eczema or other atopic conditions. So allergy testing can be great if there's a strong clinical history, like that child we learned about at the beginning of this presentation. But preemptive testing, so for example, just coming in and testing to a bunch of different foods, is not predictive and has a really high chance of over-diagnosing allergies. Another misconception is that the higher the test, the more severe the allergy. So I hear that, oh, the allergy test was huge, so the allergy is really severe. That is not the case. The bigger the allergy test, the more likely the person is to truly be allergic, but it doesn't speak to anything about the severity of the allergy. IgG testing has no role in the evaluation of food allergy or intolerance, is actually a marker of tolerance, not intolerance. And the CSACI has put out a wonderful statement on IgG testing as well. So this is a basic diagram on how to diagnose and manage food allergy. The biggest thing is the history. So what was, I always say child, but what was the child or adult eating at the time? Go back to those common foods, because those 8 or 10 are by far the most common triggers of allergic reactions. Was it a new ingestion? Was it eaten within a short period of time prior to the reaction? And was there anything else new at the time? Is it possible that they had a new medication at the time? I had one child where it was a possible food allergy. It ended up being a stinging insect allergy. So just making sure there was nothing else new at the time. Skin prick testing or blood testing for serum-specific IgE is the next step. If it's clear, you go on to management, have an epinephrine auto-injector, stay away, talk about anaphylaxis risk. If it's unclear, that's when you think about an oral food challenge or taking the food out of the diet. This is more with the proctocolitis stuff when we think about elimination diet and food symptom and diary. When to refer to a specialist. Primary care has a huge role in allergy. We're going to talk about allergy prevention in a little bit, promoting early introduction of allergenic foods in an age-appropriate way, reassuring around possible, corollaries with food allergies if there's a non-compatible history. So for example, allergists cannot test for hyperactivity due to a possible food, brain fog due to a possible food, etc. Managing comorbidities. So for example, in a child with food allergy, making sure asthma is well controlled is so essential. And then ensuring that patients, families have auto injectors with them. They have an emergency plan. They understand when and how to use an auto injector. When to refer to an allergist. If there's a possibility of a food allergy, it's really helpful to have an allergist, immunologist involved for the diagnostic portion. Any patient who's experienced an anaphylactic event should consider a referral to an allergist immunologist in order to determine the cause of the reaction if there was one, and to prevent future exposure to the allergen. Also, dietitians can play a huge role. I know some primary care clinics have a dietitian, and a huge resource, especially in children where there's multi-food allergy and there's many food avoidances. Also in breastfeeding parents, if they're avoiding multiple foods due to proctocolitis, it can be really, really helpful to have a dietitian involved. In terms of how often children, adults see their allergist, this varies quite a bit, but in general, if it's food allergy alone, it's about once a year. We repeat test about once a year to determine whether clinical tolerance has developed. We follow those tests over time, see if they're getting smaller, re-educate, screen for asthma and other comorbidities, go through how to use the auto injector again. Reevaluation is also helpful because food allergy is such an interesting space and so much has changed. So one example is baked milk and baked egg. We now know that up to 80% of children in particular who are allergic to milk or egg can tolerate milk and egg in baked goods. There are some of us who are even slowly progressing these milk or egg allergic children from well-baked to less well-baked to well-cooked to less well-cooked egg and milk over time. In terms of medical change, so Benadryl remains, or diphenhydramine remains, the most prescribed or the most commonly recommended antihistamine. There's now a CSACI statement strongly advocating that it should be behind the counter only because of its sedative effects, among others, with this move more towards non-sedating antihistamines. There's more and more epinephrine auto-injectors available, different needle lengths available, and then food desensitization or oral immunotherapy, which I will talk about. And that's what we'll talk about next. So historically, food allergy treatment has been stay away from the allergen, carry an auto-injector, come back once a year and we'll retest you. Food desensitization, ironically, though, has been around for over 100 years, first reported in the Lancet to Egg in 1908. There's really been a huge influx of studies in the past 10, 15 years or so, and now there is a formal pharmaceutical peanut desensitization medication that is FDA approved in the US, not in Canada. So oral immunotherapy, or OIT, is food desensitization. It is always done under the management of a food allergist. And basically the process is under medical supervision, you start with a very, very tiny amount of the allergen in an age-appropriate way. At regular intervals, increase the amount of allergen that person, and often that child, is eating over months until they're eating a maintenance dose. And then they stay at that maintenance dose theoretically indefinitely, but then we start to skin test much more commonly or do blood tests much more commonly, because for some children that skin test will drop over time. And this is what it looks like. So there's a desensitization phase where you're sort of teaching the immune system to become less reactive to the allergen. The child or adult is seen in the allergy office, started with a tiny dose. They eat that every day for a certain interval. In my office, it's usually 2 weeks. Then they come back, they get the next dose, et cetera, et cetera, et cetera. The number of doses vary by the type of food. For me, for peanut, it's 8. For sesame and tree nuts, it's somewhere between 11 to 13. And then they're at a maintenance phase where they have ongoing regular ingestion of this very specific amount of that food. What we know that oral immunotherapy does is it increases the threshold dose. This child or this adult is eating every day a food that they are allergic to. Over time, that calms down the allergy cells and it effectively increases the amount that they would have to eat before they react. So this provides, in general, what we call bite protection, meaning a child who is sesame allergic can go into a bakery and maybe they can't order a sesame treat, but they can bite into something that had sesame by mistake, or they don't need to worry about people washing hands and changing dishes and all that kind of stuff, because small amounts of cross-contamination are not going to trigger a reaction. However, if OIT is stopped, it is possible that that threshold is reduced again. It is theoretically considered an ongoing long-term therapy. It causes similar immune changes to allergy shots, and it is now supported by Canadian and American and other international clinical guidelines. So this is an example of what OIT does. If a child reacted to 30 milligrams of peanut protein before they started, by the time they're done, if they're having 300 milligrams of peanut protein, a little bit more than one peanut, this would give a 99.8% reduction in the chance of having an allergic reaction to the amount of peanut expected to be in a peanut-contaminated snack mix chips. So basically prevents them against having reactions due to accidental exposures in general. We don't know whether OIT cures allergy. This is an ongoing source of debate among allergists. I will say that when used in very young children, especially otherwise very young children, we are seeing skin tests convert to negative. Whether that means cure or whether that just means desensitization, we don't know. But we are seeing kids be able to eat more ad lib as opposed to eating a very specific amount every single day. But we really don't know yet that this is a curative therapy. It's really more meant to be an ongoing therapy for desensitization. There are some safety issues associated with OIT. It can cause anaphylaxis. In children, the risk of that is about 4% if you're young. It increases over time. Some foods are more likely to cause allergic reactions than others. And the most common time to have an allergic reaction is when you're going up a dose, which is why that's always done in the allergist's office. Ongoing controversies are efficacy, how well this actually works. Does this actually cure, or does this actually more just desensitize while you're using it? And then there are feasibility issues with this. It's a hard thing for families to do. You're in an allergy office every few weeks. The child or the adult has to eat that food every single day at home. For kids, it can never be within a few hours of bedtime. So it has to be at a specific time of day. There is no cost in Manitoba to see an allergist to have this done, but there is a cost to get the food. Education is essential with OIT. Make sure to use the auto-injector if there is an allergic reaction, to let the allergist know if there's been an allergic reaction, to manage and control asthma for all the reasons we talked about earlier. And eczema gets worse like 99% of the time in children on OIT. So really, really good management of the skin too. Other management approaches for food allergy, I talked a little bit about baked milk and baked egg, and some of us under some stringent circumstances are using some ladders for baked milk and baked egg that were first developed in Europe that allow the slow progression to sort of less and less baked and cooked forms over time under allergy supervision. Xolair or omalizumab is now approved as monotherapy for food allergy in the United States, not in Canada, but it reduces the likelihood of reacting to foods and can be used for multi-food allergic people. So this is a super interesting space. I think in the next 10 years, there's going to be much and much more that we can do. Some of us are looking at sublingual immunotherapy where it goes under the tongue and doesn't really trigger anaphylaxis. In the US, it's being trialed. In Canada, there's a peanut patch that goes on the surface of the skin and does something similar as sublingual immunotherapy. It just increases the amount of food that would be required to trigger an allergic reaction. Now, prevention of food allergy. So 20, 30 years ago, the evidence was to stay away, introduce peanut at 2 to 3 years of age. There was really no significant evidence for this recommendation. It was based on a pathophysiologic basis that the gut takes some time to mature, so it would make sense to wait on feeding. Observational data made researchers hypothesize that eating early would actually lead to less allergy. There was a really interesting study looking at 2 different countries, one where peanut allergy prevalence was super high, one where peanut allergy prevalence was super low. And the only difference between those 2 countries was that one had a peanut containing snack that was fed in infancy. And so infants, very young infants, were being exposed to peanut very, very early. In the other country, they weren't feeding peanut until 2 to 3 years of age. The first randomized controlled trial to show this was the LEAP study. In allergy, we call it a leap forward in our specialty, learning early about peanut. What they did in the study was they took 640 high-risk infants who had eczema or egg allergy. They randomized them to either avoiding peanut until 5 years of age or eating peanut regularly 3 times a week until 5 years of age. And what they found at 5 years of age was over an 80% reduction in peanut allergy in the infant group that ate peanut early. They actually further stratified these infants to skin test negative and skin test positive, and they found a reduction in peanut allergy in both groups, which suggests that there wasn't just a primary prevention effect, but also a secondary prevention effect because it prevented peanut allergy even in children who already had positive skin testing. So we really have the best evidence for peanut, that eating early reduces peanut allergy, but there's now been several randomized controlled trials for egg as well, for cow's milk as well. It's getting to the stage that it's almost considered unethical to do early introduction trials because there's been such a strong demonstration of benefit. There is no evidence that feeding early is harmful. Some babies will be allergic at first introduction. The risk of severe anaphylaxis in infancy is rare. So I get questions, do I have to sit outside the emergency department to feed peanut? The answer is no. There has never been a fatality on first ingestion of a food in infancy. And there have been some very good studies that show that severity of anaphylaxis increases with age. It's very, very rare in infants. So we now know that feeding early is thought to be preventative, definitely for peanut, probably for egg and milk. We think the mechanism of sensitization is the same for common allergens, meaning if it's preventative for some allergens, it's probably preventative for most or all of them. But the challenge is implementation and logistics. So there's a lot of fear around feeding these foods early. Other children in the house with peanut allergy or other allergies can create difficulties. It's important for families to know that peanut exposure on the surface of the skin or through inhalation will not cause anaphylaxis. So, for example, if you want to feed a baby peanut, but there's an older child who is peanut allergic in the home, it is safe to have peanut butter in the home. Obviously, the older child couldn't eat the peanut butter, but smelling peanut butter, even peanut butter touching the surface of the skin, it will aggravate the skin, but it is not going to cause anaphylaxis. I was part of the CPS guidance on early introduction and food allergy prevention. An important point is that we are not looking for early introduction to compete with breastfeeding. One of our statements is that breastfeeding should be protected, promoted, and supported for up to 2 years and beyond. In terms of when to introduce, we use the term around 6, but not before 4 months in our guideline, and have gotten a ton of questions about why we use that terminology. Why didn't you just say 4 to 6? And the reason we didn't is because every infant is different. And I would say for a low risk infant where there isn't a strong family history of allergy, the child doesn't have eczema, the parents don't have allergies, and there is strong motivation for the breastfeeding parent to continue breastfeeding, I would wait until about 6 months. But in a family where the child is developmentally ready, has eczema, has an older sibling with food allergy, and there's a really high motivation to do anything they can to prevent food allergy, I would move more towards 4 months, but it's really that 4 to 6 month interval. In terms of what would make an infant at risk, it would be if they have allergies as well. So in general, in an infant, that would be eczema, or if there's an immediate family history of allergy. The testing controversy. So our CPS and our Canadian Society of Allergy statements both say do not preemptively test prior to feeding. The only time I preemptively test is if a family tells me that they will not feed if I don't test. We know that preemptively testing carries up to a 40% chance of a false positive test result that will lead to potentially unnecessary food avoidance. It medicalizes feeding. It risks delaying introduction, which we know is the only way really to prevent food allergy. There's only one guidance that I'm aware of in the world that recommends preemptive testing prior to peanut in high risk babies. But as I said, I will preemptively test rarely to provide support to the family with a discussion with the family of the limitations of testing if we embark that way. Practical ways to feed. One at a time, a small amount, start low, go slow, make sure it's age appropriate. There have now been several studies showing choking rates going up because of feeding whole peanuts. So of course, no whole nuts early in life. It should always be in an age appropriate way. An easy way to feed peanut butter is to take some smooth peanut butter, mix it with boiling water so it's super, super liquidy, wait for it to cool, and then add it to a food that the infant's already tolerated, like applesauce or sweet potato puree. Another really important point, food on the surface of the skin, especially in a child with eczema, can look like an allergic reaction if it gets a bit red. And we think that you become allergic through the surface of the skin. So for high risk foods like peanut, as much as possible in the mouth, not on the surface of the skin. Always one at a time in terms of the common allergens, so nuts, seeds, milk, egg, grains, because if you feed many at the same time and there's a reaction, it can be really, really hard to figure out what the reaction was to. And if you start testing lots of different foods, you probably will get some false positives. And then the big, big thing, I was actually an author on this. We just put out a statement through the CSACI about regularity of ingestion. And this is often a point that's missed. Once the food is in the diet, keep it there. It's really, really important to remind the immune system, if it's tolerated a food, that it should continue to tolerate the food. And I've had many kids in my practice that have been exposed to, say, peanut at 6 months, didn't react, but then it wasn't part of the diet. And then a year or two later, they're at a birthday party or they're somewhere and they bite into something that has peanut and they have an allergic reaction. It's really, really important once it's in the diet that it remains in the diet. We practically don't know what that means in terms of how often it should be fed. I often will say about once a week. Our guidance says a few times a week. Food Allergy Canada has awesome resources on how to feed kids. There's a resource called Feed Early, Feed Often, and it's free. It's downloadable on their website. The link is at the bottom. It has age-appropriate forms and recipes. The other big importance is that the child, of course, needs to be developmentally ready to eat solids in general before they start allergens. And another little practical point, I always say that the first food shouldn't be a common allergen because it's really important to know how baby eats. You know, do they cough? Do they rub at their mouth? Do they seem to not like the food before you try something where there is a higher chance of an allergic reaction? Knowledge dissemination around early introduction continues. CPS, CSACI, Food Allergy Canada, other organizations are really working hard to try and turn this advice into common knowledge because it has been a huge change in how we view allergy prevention. Feeding early is most likely to benefit high-risk infants. They're the most at risk, of course, of having an allergic reaction, but on a population level, peanut allergy will be most reduced by early introduction to all. And there is no evidence of harm in feeding early broadly, instead of just limiting it to high-risk infants. Take-home points. Keep foods in the diet. Really, really important, especially peanut. In very atopic people, like children with severe eczema, even a few months has been reported to lead to allergy. That's really a take-home point there. And if you're interested, there is a CSACI statement on that on the website. Get it in the diet, keep it in the diet regularly if it's tolerated. So different food-based interventions, we have introduction, we have diagnosis, and then we have treatment. So for early introduction, you prevent allergy some of the time. There are now some studies showing that even with early peanut introduction, we don't prevent peanut allergy all of the time. It is far superior to prevent allergy than diagnose and manage it. In general, you're looking at infancy. And the method is feed in an age-appropriate way, one at a time. If it goes well, keep it in the diet. If there's a reaction, let your healthcare provider know. It can be done at home. For oral food challenge, this is really done in the allergy office to definitively diagnose allergy when the clinical history is incompatible or there's some gray area there. It does sort of quote unquote discover the truth about allergy. Most of the time there's a reaction or there isn't. It can be done in any age under medical direction. And then OIT treats allergy. It really provides desensitization. We don't know to what degree it provides quote unquote sustained unresponsiveness or cure, but it definitely provides bite protection. For some families, it's very helpful and improves quality of life. For some families, it doesn't. It can be done at any age, but there is definitely emerging evidence that the younger you are, the more effective it is, and the less likely it is to lead to side effects. So back to the family case. This 3.5-year-old boy that was new to your practice, his history is highly consistent with peanut allergy. If his testing supports the clinical suspicion, he will be likely labeled as allergic. Previous reactions don't predict future reactions. Skin test size doesn't predict severity. What will we do about it? Avoid, have an auto-injector, have an anaphylaxis action plan, consider referral to an allergist who can test, counsel and educate, follow to assess for resolution or consideration of new treatments like immunotherapy. For a pregnant person, a new baby is at higher risk because there is a family history of allergy. That baby, we would recommend to start early introduction at early as 4 months of age if baby is developmentally ready. We no longer recommend any dietary avoidance in pregnancy as a means of allergy prevention. In fact, there's a few emerging studies, it's not definitive yet, but there's some early evidence that if pregnant person eats peanut while pregnant and then peanut while breastfeeding, it may reduce the risk of peanut allergy. Key take-home points. IgE-mediated allergy is a subset of food reactions. It has characteristic symptoms, skin most common, followed by respiratory, followed by GI, followed by cardiovascular. They come on quickly, they go away quickly. And for skin, you're looking more at urticaria, hives, welts, swelling, as opposed to erythema. Diagnosis of food allergy is based on a clinical history and IgE-based testing, but you need that clinical history. Testing alone will vastly overdiagnose allergy. There's more and more treatments other than avoidance that are becoming available for food allergy. OIT is the big one that increases the threshold dose of food required to cause an allergic reaction. For prevention, peanut allergy, likely many food allergies, can be prevented with early introduction, but also ongoing regular ingestion. And referral to an allergist can help with diagnosis, education, and following to assess for resolution and consideration of new treatments. Thank you very much for your attention, and I'm happy to take any questions if you have them.
So we are waiting for questions here. If the participants had any questions, they can type it on Elissa Abrams section, please. Thank you.
So Elissa, there's a question here. Can you talk about the different epi auto-injectors available and what one to choose?
Sure, I definitely can. It's just that this is a area that's changing quite a bit in terms of what's available and what is not available. There's a few different auto-injectors. They work different ways. There's a 0.15 milligram that in general, we say should be used up until a child is 25 kilograms. The monograph says 30, but we switch over at 25 because you're vastly underdosing at 25 kilograms. And then a 0.3, Emerade, which is not available in Canada right now, also had a 0.5, but that's not available right now. EpiPen has been available forever. There is also Allergic, although at periods of time that is discontinued in Canada as well.
Okay, another question here, is the low incidence of anaphylactic death predicated on modern treatment and extensive availability of auto-injectors?
So that's a great question. I don't know the answer there, although, most, even in our families, we always recommend using the auto-injector. We always really push using the auto-injector, but your body does naturally produce epinephrine if you're having an allergic reaction. And for most people, they will get better. I'm not sure to what degree it is predicated on modern treatment, because if you look at compliance with using auto-injectors, it's shockingly low. We've done a little bit of that work in Canada, but certainly what we do know is the converse. In those rare fatalities, the one risk factor that is consistently identified is that the auto-injector was not used.
Do you have a theory on why wheat and soy allergies are diminishing?
Also a great question. And I don't have a great theory there, Lana. I don't know if you do. We're seeing it more and more move into the non-IgE mediated space, whether they were never that prevalent to begin with, or whether just the mechanism of how they're produced or how our bodies respond to them is changing. We're just seeing the types of reactions with them to be very different, to be non-IgE mediated anymore, and as opposed to anaphylactic.
Another good question here, is there a role for primary care likely in rural area to be doing skin testing for patient convenience, or should we defer to allergy in your opinion?
So, of course, we want people to have access to care, but in general, I would say our preference would be that allergy testing is done by an allergist. And the reason I say that is because there is huge false positive rates on allergy testing. We see this all the time, and it can unfortunately not only just lead to sort of food avoidances and potential for malnutrition, but we know that feeding early prevents food allergy. And there's this paradoxical risk that if something's tested that didn't need testing to, for example, you could actually increase the chance of true allergy in that child just through avoidance alone. So I would say in general, it would be preferable if an allergist is involved for allergy testing.
And actually, I'll just add in that one of the allergists in our clinic has actually been going to various northern communities to be able to do testing. It's a little bit more convenient for patients. So that's a good thing that's been started. And next question, can children with a sunflower allergy eat something that containing sunflower oil?
So sometimes children are allergic to protein, not fat. The IgE-mediated allergy is directed towards the protein in the food. And I do have some children in my practice who are sunflower allergic, who can eat something containing sunflower oil, or peanut allergic, who can eat something containing peanut oil. That being said, I'm always cautious with it. And I'd always be very careful doing that, for example, in a different place or in a remote location. But yes, the allergy is to the protein, not the fat. So if it's pure fat, it's unlikely to cause an allergic reaction.
And then can you comment on the efficacy of the new intranasal epi?
Yeah. Sure. So Neffy, which is intranasal epinephrine, it's like an epinephrine nose spray that has been newly approved in the US. They just did a big presentation on this at the last annual American Academy of Allergy meeting. So it does seem to be in the studies very effective. I know there's a bit of trepidation of how that's going to translate in the real world, but it does seem to be very, very effective, equally effective to the intramuscular form. And what we're hoping is that there'll be less trepidation with using it. There's a big barrier to using the auto-injectors right now is that needle, in particular in the pediatric population. The intranasal form is just basically a squirt up the nose. So that is the hope, that it will be much more widely accepted.
Okay, and I think that was the last of the questions in perfect timing. So thank you very much for that great talk on food allergy and everything that's changing in the last number of years. It's definitely a new world of food allergy than even when I started in the area. Okay, so our next presenter will be Dr. Rubin. Just going to make sure she gets everything up here. Okay, so Dr. Tamar Rubin is a pediatric and clinical immunologist and allergist at Children's Hospital Winnipeg and program director for the Pediatric Clinical Immunology and Allergy Training Program at the University of Manitoba. She serves as the immunology lead for the Department of Pediatrics, and recent achievements have included clinical implementation and ongoing evaluation of the Manitoba SCID newborn screening program, establishment of a multidisciplinary joint immunology bone marrow transplant clinic at Cancer Care, and the development of a national immunology curriculum for allergy and immunology subspecialty residents. Her clinical and research focus is pediatric inborn errors of immunity, and she is actively involved in local and national products, including development and implementation of the Canadian Inborn Errors of Immunity National Registry, a clinical trial of gene editing in CD3D SCID, and primary immune deficiency treatment consortium studies of SCID and chronic granulomatous disease. Thank you very much, Dr. Rubin, for coming to speak to us today.
Thanks very much, Lana. And so I'm pleased to talk to you about immunodeficiency in primary care. Hopefully everyone can see my slides. Can I get some confirmation that they're showing up there?
Looks good.
Okay, great. So here are my disclosures. None of my disclosures have any impact in relationship to the presentation today. And again, a reminder that this is an accredited learning session. So here are my objectives. My hopes are that by the end of this presentation, you'll be able to better categorize diseases of the immune system into the different categories that I'll present today. I want you to be able to recognize red flags that should indicate a patient might have an inborn error of immunity or primary immune deficiency, and know when it would be appropriate to make a referral to a clinical immunologist. I'll also give you an approach to assessing and diagnosing inborn errors of immunity, and then we'll go over various treatment options and the important role of the primary care provider in these patient groups through providing some patient cases. So what are inborn errors of immunity? So inborn errors of immunity is the new terminology to describe what we used to call primary immune deficiency diseases. When one part of the immune system is either absent or not functioning properly, that can lead to an immune deficiency disease or an inborn error of immunity. And the term inborn or primary is to denote the fact that these are genetic diseases. And that's in contrast to secondary immune disorders, which is when something external to the immune system is acting upon it to impair its structure or function in some way. The old way of thinking about immune disorders is kind of relates to the name primary immune deficiency. So that understanding was thinking that immune disorders are just these extremely rare, extremely severe disorders where individuals often early in life and infancy are susceptible to pretty much any and every infection, and they often get fatal or life-threatening infections in infancy. Our new understanding of this group of disorders also is reflected in the name inborn errors of immunity. And we now understand that this group of disorders may or may not result in a predisposition to infection. And if there is a predisposition to infection, it may be severe multiple types of infection, or it may be a predisposition to a limited number of infections, even one type of organism or one type of pathogen. And in addition to infectious susceptibility, patients may also present with a wide variety of symptoms and signs that relate to immune dysregulation. And what I mean by that is patients with inborn errors of immunity may be susceptible to autoimmune diseases, to allergic diseases or atopy. They may have abnormal inflammation, so either too much inflammation that doesn't slow down when it should, or not enough inflammation when there should be an inflammatory response. Patients may also have susceptibility to cancer or to non-malignant lymphoproliferation. And it's also important to recognize that patients with inborn errors of immunity may not present with infection at all. They may present with some of these other extra infectious immune dysregulation symptoms. And there can be overlap. So patients may present with any or all of these different manifestations. So how common are inborn errors of immunity? Well, one thing that's important to know is that over time, we've become aware of more and more unique single gene disorders causing inborn errors of immunity. So in the 1980s, we only knew about one single gene disorder causing immune deficiency or inborn error of immunity. And now in 2024, we've surpassed 500 unique single gene disorders that cause inborn errors of immunity. And that number is continuing to increase on a regular basis. That we expect that in the next 10 years, you'll see an even larger number there on that chart. This is a population-based study looking at the prevalence of inborn errors of immunity. And this study looked at national administrative healthcare databases in the US. And this particular study had data comprising about 10% of the US population. And their prevalence estimates of inborn errors of immunity found about 5 in 10,000 individuals that had private insurance, and about 4 in 10,000 individuals that were publicly insured had inborn error of immunity. And that's actually quite a bit higher than previous estimates of how frequent this group of diseases was, which was taken from registries and estimated that it was about 1 in 10,000. So we're talking about 1 in 2,000 individuals who have an inborn error of immunity. And you can also see that there is an increase in the prevalence over time, which is probably a reflection of increasing awareness amongst healthcare providers as well as the public about this group of disorders. So what about Manitoba? As I showed you in that previous slide, there are about 500 unique single gene disorders that cause inborn errors of immunity. And each one of those single gene disorders is rare. But when you think of them collectively, inborn errors of immunity are seen in about 1 in 2,000 individuals. So these are diseases that are as common as cystic fibrosis or lymphoma. And if you include the most common inborn error of immunity, selective IgA deficiency, which is an absence of IgA antibody alone, that's seen in about 1 in 300 individuals. And that data comes from blood bank data. That being said, many of those individuals are not symptomatic. Then when we think about these really severe, but very early onset disorders like SCID or severe combined immune deficiency, also known as the bubble boy syndrome, the rate of that is about 1 in 60,000. And that data comes from newborn screening data for the United States. So 1 in 60,000 live births includes SCID. But we also know that looking at studies prior to the implementation of newborn screening in Manitoba, we knew that SCID and SCID-like disorders are much more common in Manitoba. And retrospective studies estimated a prevalence of about 1 in 15,000 live births, so significantly more common in Manitoba. And since we started newborn screening for SCID in September 2020, in Manitoba, we've seen about a 1 in 10,000 live birth rate of SCID. So definitely more common. And then when we think about very rare but Manitoba unique disorders like IKBKB deficiency, in select northern communities, the prevalence is about 1 in 700. And in some communities, some of which only have a few thousand individuals, the carrier rate of these disorders is 1 in 13. So we can certainly expect that in Manitoba, we're seeing more frequent inborn errors of immunity. And we have much more to learn about the prevalence, but in Canada and in Manitoba, it is higher than probably what I showed you in those previous slides about the general prevalence. Okay, so when do inborn errors of immunity present? When are they diagnosed? Well, these are genetic disorders, so it's not unexpected that a significant proportion are diagnosed early in life. So about a quarter to a third are diagnosed in infants from 0 to 6 years old. Really at any age, patients are diagnosed with inborn errors of immunity. But what I really want to highlight here is that half of individuals with inborn errors of immunity are actually diagnosed over the age of 30. Some of that relates to a lag in diagnosis because of the time it takes to suspect and evaluate these patients, but it's also because some patients first present with symptoms in adulthood. And even people some people with inborn errors of immunity will even start presenting with symptoms in their 60s and beyond. And so don't discount the possibility of an inborn error of immunity just because a patient is developing symptoms at a later age. Okay, so when we're thinking about the possibility of an inborn error of immunity, we want to start by making sure we're considering possible secondary immune deficiency and making sure that we've ruled out that. So medications are a big cause of infections or what might look otherwise like an inborn error of immunity. And in particular, things like steroids, chemotherapy, biologics and B-cell depleting agents, anti-epileptics, and even natural products that a patient might be taking. We also want to consider infections, viruses, in particular, as well as some bacterial infections that may suppress the immune system, HIV, tuberculosis, measles, influenza, or chronic infections that haven't been treated. For a patient who's repeatedly getting infections in the same area, maybe the same lobe of the lung or in the same sinus, they may have a structural or anatomic problem that needs to be addressed. Patients with immotile cilia, so ciliary dyskinesia, cystic fibrosis, or who have an indwelling line are also prone to infection, and that may be the explanation for their frequent or unusual infections. Then there's general medical conditions that can result in immune system impairment, for example, diabetes, renal insufficiency. Patients may also be losing parts of their immune system through the gut, through the kidneys in situations like nephrotic syndrome or protein-losing enteropathy. Malnourished patients may have an impaired immune system, lymphatic malformations, or either anatomic or functional asplenia. And then, of course, malignancy, in particular lymphoid or blood-based cancers, can produce an immune deficient state, as well as the treatment for those disorders. So I'd like you to just reflect and think, what are the signs and symptoms that would make you concerned that a patient might have an inborn error of immunity? So the Jeffrey Modell Foundation, which is a patient organization based on literature reviews and evidence, have compiled a list of warning signs for primary immune deficiency. And on the left, we have warning signs in pediatric patients, and on the right, warning signs for adult patients. And some of them are similar between the two. So for example, frequent ear infections in the last year. For pediatric patients, it's 4 or more in a year. For adults, it's 2 or more in a year. Serious sinus infections, 2 in the last year, especially if there's no allergies. Multiple months on antibiotics without effect or needing intravenous or IV antibiotics. For adults, having a pneumonia more than once in a year. For children, more than 2 in a year, and for adults, more than 1. Failure to thrive in infants, recurrent deep skin or organ abscesses, persistent thrush in the mouth or fungal infections of the skin, needing frequent antibiotics or IV antibiotics to clear infections. And then, of course, family history, as these are genetic disorders, although there may not always be a family history in these cases. In adults, additionally, other warning signs can be recurrent viral infections like frequent colds, herpes infections, warts, condyloma, or infections with non-TB mycobacteria, which are normally harmless mycobacteria. If patients have 2 or more items on either of these lists, then you should consider the possibility of an inborn error of immunity. It is, of course, important, though, to recognize that these signs are neither specific nor sensitive. So studies that have looked at how well these warning signs perform have found that if you apply these warning signs to patient records, the sensitivity is about 50% and the specificity is about 15%. So really not very good. And some of the items on the list that are more specific and more sensitive include family history, needing IV antibiotics for sepsis in children, especially those with neutrophil disorders, and failure to thrive in those who have a T-cell disorder. If you look at patients who have suspected inborn errors of immunity and then you apply these signs retrospectively to them, about a fifth of patients who likely have an inborn errors of immunity would actually be missed if you just use these signs. So in other words, these signs are not enough, and in some cases are going to overdiagnose or overpick up individuals with inborn errors of immunity, but they're at least a useful start. So although we have a very complex way of categorizing inborn errors of immunity, it's still helpful to kind of think about categories of inborn errors of immunity as either innate immune system problems and adaptive immune system problems. So the innate immune system is that rapid acting part of the immune system that recognizes general molecular patterns of pathogens. It includes things like the barriers, your skin, your epithelial layers. It also includes proteins like complements, as well as your phagocytic cells, your neutrophils, your monocytes, your dendritic cells that eat pathogens and then digest them, and do things like the oxidative burst. The innate immune system also links to the adaptive immune system by starting the early signaling pathways and alerting your adaptive immune system to the fact that the adaptive immune system should start to kick in. The adaptive immune system is more specific. It responds not just to like a pathogen pattern, but to a specific organism, and it gets better and better over time. It just takes a little bit longer to start to respond. And when we get immunizations, we're trying to stimulate our adaptive immune system, our T cells and our B cells to respond. So B cells are able to make antibodies eventually, and T cells can help those B cells make antibodies. They can help those phagocytes digest organisms that they've eaten, and they can also directly kill virally infected cells. So T cells are quite central to your adaptive immune system. We'll sort of focus on different categories of the of immune disorders, including complement disorders, phagocyte disorders, which are part of the innate immune system, and then adaptive immune system problems such as B cell problems, also known as humoral disorders, and T cell disorders, also called cellular or combined defects. So there are some general clues that we can use to determine, what arm of the immune system, what part of that immune system that I showed you might be affected in a patient. So, for example, if patients are getting infections, which they may or may not be depending on their specific disorder, if it's a T cell problem, we tend to see infections with gram-positive and gram-negative bacteria, as well as mycobacteria. They are going to get viral infections with typical viruses like paraflu and adenovirus, but also herpes viruses like CMV and EBV. They will be at risk of fungal and parasitic infections like Candida, pneumocystis, and cryptosporidium. And infections can occur at sinopulmonary cell sites, as well as gastrointestinal tract, as well as invasive infections like sepsis, meningitis. Associated features may be if they have a T cell problem, then they can get vaccine-associated viral and vaccine-associated bacterial infections, for example, disseminated BCG or infections with rotavirus after getting the vaccine. Patients who have B cell problems purely tend to get infections with encapsulated bacteria, for example, strep and H flu. If they're going to get viral infections, they're particularly prone to enterovirus, and they may get chronic parasitic infections, in particular chronic giardia and cryptosporidial diarrhea. Typically, they will get sinopulmonary infections like otitis media, sinusitis, pneumonia, bronchitis, although they can also get meningoencephalitis or arthritis. And with the meningoencephalitis, that is particularly enterovirus meningoencephalitis in patients who have profound or complete B cell deficiencies. As well, patients who have B cell or humoral immune deficiencies are particularly prone to autoimmunity, as well as cancers like lymphoma. For those patients who have phagocytic problems, they're prone to certain types of bacteria like staph, Pseudomonas, and Serratia, and they don't tend to get viral infections. They are prone to fungal infections like Candida and Aspergillus, and the types of infections they tend to get are deep-seated, so organ abscesses, osteomyelitis, and skin infections. And if they have a problem with neutrophil number, they are also prone to gingivitis, gingival recession, and gum disease. And they may present with associated features like delayed separation of the umbilical cord in an infant or poor wound healing. Patients with complement disorders tend to get encapsulated bacterial infections like pneumococcus, but they're also particularly prone to meningococcal infections. And so if you see an individual with any meningococcal infection, and definitely if they have recurrent meningococcal infection, you should think about a possible complement disorder. They tend to get sepsis, meningitis as the site of their infection. And if they have a problem with their early complement system, they're also prone to autoimmunity, things like lupus and other autoimmune diseases, including affecting the kidney. Okay, so how can we approach assessing and diagnosing a patient who has a possible inborn error of immunity? Well, we want to take a really detailed history, and you heard in the food allergy talk how important it is to take a history, because that really is our main way of trying to find out if a patient might have an inborn error of immunity. So of course, the infection history may be important, and we want to take a really detailed history, focusing on things like recurrent infections, severe infections, odd infections like opportunistic infections or unusual organisms. We want to know if a patient might have required hospitalization or IV antibiotics or IV antimicrobials to treat their infections. We want to inquire about autoimmunity, and that can be really any kind of autoimmune condition. Frequently, we see autoimmune cytopenias, but we can also see colitis or inflammatory bowel disease, arthritis, malignancy history, in particular lymphoid and GI-based cancers, and then sort of those other things like failure to thrive, as well as things like atopy or allergic condition, developmental delays, reactions to live vaccines, delayed separation of the umbilical cord. And then we want to take a very detailed family history. So inborn errors of immunity often, although definitely not always, have a family history because these are genetic disorders. So sometimes an individual has a de novo variant or de novo genetic change, meaning no one else in the family's had it. But there may also be a family history, whether autosomal dominant, autosomal recessive, or X-linked. So we'll ask about consanguinity or coming from a small community where there may be a founder variant, and that can be seen in cases where there's an autosomal recessive condition. We want to ask about unexplained or early deaths, affected males, which would suggest a possible X-linked disorder, and then a family history really of any of the above findings: infections, autoimmunity, cancers, or known immune deficiency or immune disorder. So with respect to infections, we want to ask the when, what, and how. So when did infections first start? Was it under the age of 6 months, over the age of 6 months? That can be a clue as to whether or not it's a T cell or B cell disorder. How often do infections happen? What are the circumstances? We know that children who are young, children in daycare, may get 8 to 10 colds a year. Those colds can last a week or so. And a patient who has asthma may have protracted coughing for even longer after an infection. And so we want to get all those details about the nature of the infections. What type of infections are they having? Are they getting bacterial infections, viral infections, fungal infections? Where are the infections happening? Are they leading to unusual complications like an ear infection that turned into mastoiditis, or a pneumonia that became a complicated pneumonia with empyema, for example? If the pneumonias are happening, are they happening in multiple lobes of the lung, different lobes each time, or always in the same place? Is there an aspiration risk? And how do they respond to therapy? As well, are they getting a normal response to infection? For example, are they developing a fever or pus, or are they not? And have there been any complications of their infection over time, like bronchiectasis? So after we've taken a detailed history, as well as getting details about infections if they've happened, we want to do a full physical exam. So what are some things to focus on the physical exam for a patient with a possible inborn error of immunity? Well, we want to look at their general status, and we want to look at their growth parameters. In children, we want to know how they plot on the growth curves with respect to their height and weight. Many disorders will result in failure to thrive, short stature, and there may also be syndromic inborn errors of immunity where there are skeletal dysplasias or short stature as part of a syndrome. In adults, if they're losing weight or chronically unwell, they may not be doing well in terms of their final adult height or have lost weight. We want to look for any dysmorphic features or signs of a syndrome, for example, DeGeorge syndrome or other genetic disorders that may result in facial or body-wide features of a syndrome. Inside the mouth, we want to look for oral ulcerations, thrush, the presence or absence of tonsils, which is part of our lymphoid tissue. We want to focus on the lymph tissue. So can we feel lymph nodes, or are they undetectable? Are there enlarged lymph nodes or an enlarged spleen, which can be part of an immune dysregulatory inborn error of immunity? We want to look at the skin and nails, skin for signs of unusual rashes, signs of infections like warts, molluscum, eczema, psoriasis, poor wound healing, nails for signs of dystrophy, infection. And then we also look at the teeth and hair as well for the same reason. And then, of course, on exam, other than doing, a full head-to-toe exam, we want to look at signs that a patient might have had frequent or severe infections. So, for example, scarring in the eardrum, bronchiectasis or chronic lung disease, and other signs that they may have had an infection. So I'm going to show you some pictures of some, features that we might find on physical exam for a patient who has an inborn error of immunity. So take a look at these and see if you recognize any of these findings and what the implications are. You can see here, this is a patient who has oropharyngeal candidiasis or thrush, a patient with tympanosclerosis or scarring in the tympanic membrane that can reflect frequent ear infections. Petechiae, those can be seen in specific disorders where there are low platelets like Wiskott-Aldrich syndrome, but also in autoimmune cytopenias. This is a baby with DeGeorge syndrome, so you can see the low set posteriorly rotated ears, the small mouth and micrognathia, as well as the bulbous nasal tip. Here is bronchiectasis, so that is a frequent endpoint of many different inborn errors of immunity after frequent infections or aberrant inflammation. The absence of pharyngeal tonsils can be seen in things like X-linked agammaglobulinemia or in SCID. This is an X-ray showing a thymus, but the absence of a thymus may reflect something like SCID, or a really big amount of thymic tissue in an adult may be something like a thymoma. Severe eczema or atopy may be part of an inborn error of immunity or a primary atopic disorder. And then this is molluscum contagiosum, which is common in children, common in those with eczema, but when it's very severe or extensive, may be a marker of an inborn error of immunity. Okay, so once you've taken the history, you're done your physical exam, maybe seen some findings, you're going to do some basic blood work. And some of the things that you're going to start with include a CBC and differential, and then some basic chemistry. Your CBC and differential is very helpful to look at the white blood cells. The lymphocytes are often decreased in many different forms of inborn errors of immunity, although they can be normal or elevated. Your neutrophils may be increased or decreased depending on the specific disorder. Eosinophils can be, again, increased or normal. They're often increased in atopy, but many atopic conditions, many inborn errors of immunity, in fact, have an atopic component as well, so that may also be a clue. Platelets can be increased or decreased depending on the clinical situations. If there's a lot of inflammation, the platelets are often non-specifically elevated, but autoimmune disorders resulting in cytopenias and inborn errors of immunity can also result in low platelets. And then looking at the general chemistry, you maybe you do it in order to find a possible secondary immune deficiency state like hyperglycemia that can cause thrush, for example, or signs of protein loss that may be an explanation for a patient's low immunoglobulins or low lymphocytes. Okay, so then we can look at different immune tests to try to understand what type of inborn error of immunity our patient might have. So we can look at tests that assess the number of the immune cells as well as the function of those immune cells. Those that are bolded are things that a family doctor would regularly order. So looking at the total lymphocyte count on your CBC and differential can help you understand if T cells might be low, because lymphocytes are made up of T cells, B cells, and natural killer cells. So if the overall lymphocyte count is low, that might be a suggestion that T cells are low. And then immunologists can do some additional tests like flow cytometry, looking at the specific type of T cells and B cells. We also have newborn screening, which uses a test called TREX, which I'll talk about later, and that's more of a functional test related to T cell production. For B cell disorders, family doctors can order immunoglobulins like IgG, IgA, and IgM, and they can also look at the lymphocytes again because lymphocytes contain B cells. And then an immunologist may order more focused tests like B cell subsets or look at the patient's response against vaccines that they've previously received. If you want to evaluate for a phagocyte disorder, you can look at the absolute neutrophil count on the CBC, and then an immunologist may also further order tests to look at neutrophil function, for example, the NOBI test or the neutrophil oxidative burst index. They may also be able to measure adhesion markers on the surface of cells to look for things like leukocyte adhesion deficiency. And then for complement testing, there are numerical tests like C3 and C4 levels, which sometimes are ordered. Or if you think someone might have Urticaria-Angioedema, looking at C1 esterase inhibitor levels. And then the immunologist may also order functional tests like CH50 or total hemolytic complement. Okay, so I'll touch on newborn screening. So newborn screening for SCID or severe combined immune deficiency uses a test called TREX or T cell receptor excision circles. And that is basically a marker of T cells developing in the thymus. If patients or infants don't have a lot of T cell production or don't have any T cell production, they will have low or absent TREX on newborn screening. But remember that having a normal SCID newborn screen does not rule out most forms of inborn errors of immunity. It certainly doesn't assess for B cell or complement or phagocyte disorder, and it also will miss a few rare forms of SCID even. And so we still have to retain an index of suspicion when the history, physical exam, or lab work suggests there might be an immune disorder. SCID newborn screening will also pick up certain combined immune deficiencies that are less severe than SCID and that may still require treatment. And they will also detect non-immune issues that result in low TREX. So for example, we pick up babies with low birth weight who are premature, babies who have GI conditions like gastroschisis or necrotizing enterocolitis, congenital heart diseases, or other non-immune medical issues that result in low TREX. And some of these patients will require ongoing follow-up, and some of them, it's just a false positive screen. So in Canada, every part of Canada screens for SCID with newborn screening, except unfortunately Newfoundland and Labrador, but hopefully they will come on board soon. In Manitoba, we've been screening for SCID since September 2020. We use the TREX screen to look at low T cell production, but we also test for these very rare founder variants in genes that we see more commonly in Manitoba, like IKBKB deficiency, as well as ZAP70. Okay, so now we'll move on to treatment for inborn errors of immunity, and we'll talk about, in this section, the role of the primary care provider in co-managing these patients. So here's a question for reflection. Which of the following statements is true? A, failure to thrive is present since birth in babies with SCID. B, the presence of lymph nodes rules out SCID. C, patients should stop breastfeeding once SCID is suspected if the mother is CMV seropositive. Or D, gene therapy is the treatment of choice for SCID. So the answer to this question is C, that patients should stop breastfeeding once SCID is suspected if the mom is CMV seropositive. And in cases where SCID is suspected based on newborn screening or otherwise, patients should be advised to stop breastfeeding until we can determine mom's CMV serostatus. So what is severe combined immune deficiency or SCID? Well, it's a group of diseases that present early in life and are fatal if they're not treated. And there are many different genetic causes. All of the causes result in profoundly depressed T cell function. And because B cells rely on T cells to do their job, B cells are de facto affected whenever there is a profound T cell disorder. Patients may present with chronic candidiasis, protracted diarrhea, and failure to thrive, opportunistic infections like pneumocystis, as well as chronic respiratory viral infections like paraflu, RSV, and even CMV infections. However, in the era of newborn screening, often we don't see these infections manifest. We often will be able to screen and pick up these babies before they start to show symptoms. Classically, patients don't have thymuses or lymph nodes or tonsils, and blood work will show low lymphocytes, low T cells, and then variable levels of the other lymphocytes. But universally, they have an inability to respond to vaccines, and live vaccines can be life-threatening or fatal to babies with SCID, which is why it's so important to pick up these cases early and not give live vaccines to this group of disorders. The management of SCID, well, hopefully in most cases, in the vast majority of cases, they'll be identified before they get symptoms and come to treatment and come to immunology before they show any signs. But if they're showing signs, of course, immunologists should be contacted. Babies must not get live vaccines like BCG, rotavirus, and later MMRV. If they need a blood transfusion, they should get irradiated CMV negative blood products. They should be isolated. They'll often need protective antimicrobials and immune globulin replacement until they can get to definitive therapy. And in most cases today, treatment for SCID is going to involve hematopoietic stem cell transplant from a healthy donor, ideally a matched sibling, sometimes a parent or unrelated donor. Okay, so now we're going to go through a different patient case and go through the history and physical and management together. So this is a 14-year-old boy, 14-year-old young man with a history of left lower lobe pneumonia, discharged from hospital after having received intravenous antibiotics. He had 4 other pneumonias in the past, treated with oral antibiotics, and he has a history of frequent acute otitis media, about 4 to 5 per year. He was born at term, had normal development, and his immunizations are up to date. Parents are non-consanguineous. There is one relative in the family who died in early childhood of an unknown cause, but otherwise the family history is not remarkable. So think about what kind of things now you would look for on physical exam. So on exam, the patient's vital signs are stable and the patient looks really well. He's at the 50th percentile for height and weight. He does have some tympanic membrane scarring and has small but present tonsils and lymph nodes. So I want to highlight here that, a lot of times patients with inborn errors of immunity, especially those that are not affecting T cells, may look very well. They may actually be growing very well. So don't discount the possibility of an inborn error of immunity just because someone looks like they are growing well. What investigations now are we going to order for this patient with a severe pneumonia, frequent ear infections, meets many of those Jeffrey Modell Foundation warning signs for inborn error of immunity? Okay, so they had a CBC and differential done. They had some basic chemistry, as we talked about. They had immunoglobulins and they had vaccine titers. And what's notable in their CBC is they have mild thrombocytopenia, so the platelets are 100. They have normal chemistry, so we're doing that to make sure that we're not seeing low albumin or proteinuria or something to suggest loss of protein as a cause for low immunoglobulin. And you can see that both IgG and IgA are low for age, while IgM is normal. As well, despite having received all their routine immunizations, they're non-immune to rubella and non-immune to both tetanus and diphtheria. So now my question is, what category of immune deficiency or inborn error of immunity is this? Is this a B cell or humoral inborn error of immunity? Is this a T cell and B cell combined immune disorder, a complement disorder, or a phagocyte disorder? So this is a case of a B cell or humoral immune deficiency. And this is a patient who meets criteria for CVID. CVID stands for Common Variable Immunodeficiency. So this is actually the most common symptomatic humoral inborn error of immunity. Selective IgA deficiency is more common, but less often symptomatic. And that's why we call it common, because it's fairly common. It's about 1 in 50,000 individuals. It is clinically heterogeneous, and that's why it's called variable, because it can really range in severity and type of presentation. There are many different genetic causes for CVID. However, in the majority of cases, we don't have or know the specific genetic disorder despite doing genetic testing. There are two major peaks in terms of when this condition presents. The first peak is in the first 10 years of life, so in childhood, and the second peak is in the third decade of life, which is why family doctors need to be aware of patients who may present in their 20s and 30s with symptoms. Patients may present with infections, typically recurrent sinopulmonary and GI infections, or they may present with autoimmunity, granulomatous disease, or cancers. What distinguishes CVID from a more profound absence of B cells and agammaglobulinemia will be the presence of lymphatic tissue like tonsils and lymph nodes, although that is not sort of a definitive finding. The types of infections in CVID tend to be recurrent sinopulmonary infections, especially with encapsulated bugs that tend to colonize the respiratory tract, like strep pneumo and H flu. And over time, the frequent infections and aberrant inflammation in this disorder can result in bronchiectasis and other changes in scarring in the lungs. Patients will get GI infections, in particular giardiasis and Campylobacter, as well as cryptosporidial diarrhea. They may also get some atypical bacteria like mycoplasma and ureaplasma, which can cause joint and skin infections. CVID is managed by aggressive and early treatment of infections. So if someone might have an infection or has an infection, they should get antibiotics early and may require longer courses of treatment. Patients will also start immunoglobulin G replacement for life. This helps protect patients from getting recurrent and frequent infections, but unfortunately really doesn't have impact on the autoimmune, immune dysregulation, and cancer risk that these patients have. Patients will need careful monitoring of their lung function over time, as well as proactive monitoring and early assessment and treatment should they develop autoimmune or malignant complications of the disease. So what is immune globulin replacement? Well, basically, this is a blood product. So it's pooled donor plasma from thousands of donors. It's mainly IgG, that is the main protein in there. And IgG replacement is used in immunodeficiency to replace the IgG components of the immunoglobulins that they're not able to make themselves or that they don't have enough of. And it also has an immunomodulatory role when it's used at much higher doses, and thus is used in some cases for autoimmune disorders and alloimmune disorders. But at the replacement doses that we're giving in patients with CVID or other immune disorders, it really does have an impact on that. The indications for immune globulin replacement in Canada include primary immune disorders like inborn errors of immunity, ITP, secondary immune deficiency state, so that might be after cancer treatment or after a stem cell transplant, for example, and certain immune disorders like CIDP, Guillain-Barré syndrome, and multifocal motor neuropathy. So which of the following statements is true? Adverse reactions to IVIG are so common that all patients are pre-medicated with antihistamines and acetaminophen prior to receiving it. IVIG replacement is given at a dose of 400 to 600 milligrams per kilo every 3 to 4 weeks. C, patients with CVID should continue to receive routine immunizations to give them extra protection. Or D, we don't need to check IgG levels once patients have started IVIG replacement. So the answer is B. IVIG is given at a replacement dose of 400 to 600 milligrams per kilo every 3 to 4 weeks in those who are getting it for the indication of replacement. Adverse reactions to IVIG can happen, but we don't routinely pre-medicate unless someone has had a history of reaction. And patients with CVID, for example, don't need most of their immunizations. They do require annual inactivated influenza, COVID boosters, and certain select non-live immunizations according to their immunologist-specific recommendations, but most routine immunizations are no longer required or not indicated. And we do regularly check IgG trough in patients who are on replacement. So commonly, patients who get monthly IVIG will have reactions. Often they're milder symptoms that can be managed with things like slowing down or stopping the infusion or giving certain types of supportive medications. Rarely there are more severe reactions. In many cases, these days, we start patients on subcutaneous immune globulin replacement. So this is a form of immunoglobulin replacement that can be given by patients or their caregivers or a nurse at home through a small subcutaneous needle and given on an either weekly or monthly basis. So patients are not required to come to hospital, and systemic or major reactions are much less common with the subcutaneous route of administration. So getting back to our case, he's doing really well on IVIG in terms of infections. His levels have been therapeutic and in the normal range, 7 grams per liter. He was later switched from IVIG to SCIG, had one episode of pneumonia requiring treatment with antibiotics, but otherwise is not getting infection. He's got some mild bronchiectasis, but normal pulmonary function tests. However, recently he's been more fatigued, loss of appetite, is having abdominal pain with bloody stools, major weight loss, and the stool infectious workup that was done was negative for any bacterial, viral, or parasitic infections. So what are some things that we should be worried about in this young man with CVID? So we know that autoimmune and inflammatory complications are seen in about a third of patients with common variable immune deficiency. These can range and include things like cytopenias, gastrointestinal manifestations ranging from CVID-associated IBD, gastritis, lymphoid nodular hyperplasia, celiac-like disease, liver disease associated with CVID. They may get things like arthritis, granulomas that can infiltrate the lungs, liver, spleen, skin, autoimmune thyroid disease. So we need to be looking out for these and having a higher index of suspicion for these known non-infectious complications of CVID. Additionally, we know that about 10% of individuals with CVID will get cancer, typically in adulthood and later on, particularly non-Hodgkin's lymphoma and gastric cancers. And it's important then for patients to be aware of seeking medical attention should they start to develop constitutional signs and symptoms of infection. Okay, so as I showed you in the previous slides, we have an increasingly sort of broad definition of inborn errors of immunity and how they can present not just infections, but autoimmunity, inflammation, lymphoproliferation. And we talked about some general categories for categorizing inborn error of immunity. So T cell problems and B cell problems, which are considered adaptive immune disorders, phagocyte and complement problems, which are innate immune problems. But there's many other categories, which unfortunately I won't have time to talk about. So diseases of immune regulation, autoinflammatory disorders, so those are things like periodic fever syndromes, which involve the innate immune system, and many other categories. We aren't obviously going to talk about the 500 unique single gene disorders that we know about, but to give you some examples, some of which we talked about, for T cell problems, that includes things like SCID, which we do screening for and presents early on in life. But other examples of T cell disorders would be Wiskott-Aldrich syndrome, ataxia-telangiectasia, DeGeorge syndrome, chronic mucocutaneous candidiasis, which can have many different genetic causes. For B cell problems, that includes things like XLA and common variable immune deficiency, which we just talked about. There are some conditions that are seen in childhood, like transient hypogammaglobulinemia of infancy, which improves over time, or selective IgA deficiency, which is quite common. In the category of phagocyte disorders, things like chronic granulomatous disease or leukocyte adhesion deficiency fall into that category. And then complement disorders may include things like early complement deficiency, C2 deficiency, or late complement deficiency, C5 to C9 deficiency, or some very rare disorders like properidin deficiency. Okay, so what is the general approach to managing patients with inborn errors of immunity, no matter what their specific diagnosis? And there's kind of 4 pillars that I'll focus on. One is investigating and treating any current infection. 2, preventing future infections. 3, monitoring for complications that may not be infectious, like autoimmunity and malignancy. And then working together with the specialist team in an interdisciplinary approach. So we'll talk about these each now one at a time. So there should be early assessment when a patient with an inborn error of immunity presents with possible infection. There should be a low threshold to do some blood work and to do cultures. I want to point out here that patients who have an inborn error of immunity may be on immune globulin replacement. And so serologic testing for infection is not going to be relevant because you're going to be testing what they're getting through the blood product if you do serology. And as well, they may not even have the ability to make an antibody response to infections. So you really need to get blood and tissue samples to look for infections. Imaging may be helpful. However, there are some conditions that are radiosensitive, for example, ataxia-telangiectasia, where we want to just avoid infections, and sometimes we'll empirically treat for pneumonia when it seems like that's likely or possible. Patients who have inborn errors of immunity may not be able to clear their sinus infections, clear their ear infections, clear that cold. It may turn into a bronchitis. And so there should be a lower threshold to treat with antimicrobials, and they may require longer courses or even a second course. Remember also to consider the possibility of an unusual infection, especially if there are some unusual manifestations. Preventing future infections. So we have to be very cautious about giving any live vaccines. If you're ever in doubt or think a patient might have a T cell problem or a T cell, or really any inborn error of immunity where you're not sure, avoid live vaccines. If there's a high risk exposure, for example, to varicella or to measles, you may give them immune globulin after exposure. They need irradiated CMV negative blood products, and they may also need to be isolated or be encouraged to wear masks or be away from patients who might have infectious symptoms. Immunizations that are non-live should generally be up to date unless you've gotten specific guidance about that, but they may not require immunizations on immune globulin replacement. And many patients will end up being on immune globulin replacement therapy and may also need antimicrobial prophylaxis depending on the specific disorder. So patients should be given anticipatory guidance and know to self-monitor for symptoms of cytopenias like bruising, bleeding, early satiety, signs of malignancy like fevers, weight loss, night sweats, enlarged lymph nodes, and also be aware of the risk of chronic conditions involving the GI system and others. And finally, the immunologist is the medical home for patients with inborn errors of immunity, but we work closely with their primary care providers, with other subspecialists that manage their organ-specific manifestations like gastroenterology, respirology, hematology, oncology, dermatology, as well as dietitians, genetic counselors, as these are often hereditary conditions. And so patients really need to have coordinated care amongst their different specialists. So to summarize, inborn errors of immunity are not just infection susceptibility, and sometimes patients are not, highly susceptible to any and all infections, but rather susceptible to limited or only a few infections or no infections at all. Other features of inborn errors of immunity include atopy, autoimmunity, malignancy, and unusual inflammation. You want to rule out and investigate for secondary causes when you're considering an inborn error of immunity. Patients may be diagnosed at any age and may have symptoms at any age, so this is not just a group of childhood diseases. The principles of management in general for inborn errors of immunity include recognizing this group of disorders, preventing complications and infections, ongoing monitoring, and specialist care. And we'd always be happy to speak with you about any concerns you have about your patients with known inborn errors of immunity or suspected inborn errors of immunity. So here are some useful resources, and I appreciate your attention and would be happy to take any questions at this point. Hey, someone asked about, for celiac disease, it's an IgA serology test. And so often it comes back low, sometimes high, and what is the significance? So I would say that if IgA comes back low or absent, that is definitely an indication to, first of all, consider the patient's history and presentation, right? Like why was that test done? Could they possibly have an inborn error of immunity? And it would be very appropriate in that case to then order IgG and IgM. If they have normal IgG and normal IgM and don't really have any other history or family history features to suggest an issue, then it's quite possible that you can reassure them. If it's completely undetectable, then they may have selective IgA deficiency. If they have any history of infection, any family history of infection or autoimmunity, or symptoms that may be suggestive of an inborn error of immunity, then it may be appropriate as well to then expand that testing or make a referral to a clinical immunologist. Elevated IgE can be seen in general inflammatory states and autoimmunity. So we see it in patients with a variety of different autoimmune diseases or airway or GI inflammation. So it's not really specific, but likewise, I think if there's an abnormality in the IgA, I would go ahead and do IgG and IgM and then consider the history and presentation in deciding whether or not that patient needs either vaccine response testing or referral to a clinical immunologist.
Okay, so it doesn't look like there's any more questions for now. If any other questions come up, you can always let us know. Next, we're going to have a short break and return at 10:45, and we'll see everybody then. Dr. Karver Zaborniak. Dr. Karver Zaborniak is an allergist and clinical immunologist at the University of Manitoba. He completed his Bachelor of Medical Sciences in Immunology from Western University and completed his medical school internal medicine residency and subspecialty training at the University of Manitoba. He now serves as the program director for allergy and clinical immunology, and his interests include medical education and chemotherapy drug hypersensitivity. Thank you very much, Dr. Zaborniak, for joining us today.
Yeah, thanks for having me. And yeah, thanks to Dr. Rosenfield for helping to organize this and inviting me today. And thanks to everybody for joining. If you at all felt overwhelmed by learning all about immune deficiency in 1 hour, then this will be a little bit of a relief. We're just going to talk about hives and swelling. So let's get going. Like at the other talks today, of course, this talk is accredited and the slides were developed by the CSACI. I do have some disclosures, although they are not directly relevant to today's topic, but I have received speakers honorariums and am on the advisory board for pharmaceutical companies relating to asthma therapy. So nothing that I'm going to talk about in today's presentation. For our learning objectives today, we're going to talk about what exactly is urticaria and how do we compare and contrast acute and chronic urticaria. We're going to talk about how we approach the therapy of chronic urticaria, and then we're also going to talk about a diagnostic approach to angioedema. So first, just a bit of a thought-stimulating question. Let's think out of this list, what would be a cause for urticaria? So first option is food allergy and drug allergy, a viral infection, temperature like heat or cold, or a venom allergy, which would be from a stinging insect like a wasp, hornet, or a bee. So which of these can cause urticaria? The answer is actually all of them. So we're going to talk about that today and exactly what can cause urticaria, what it looks like, and what to do about it. The important thing is that urticaria itself is a pretty unique rash, and I would say that it's very commonly misunderstood or misinterpreted. And we certainly get a lot of referrals that list a rash as being urticarial, in which when we see them, it's very much not urticarial. But if you know the definition of urticaria, it's usually pretty easy to diagnose, and it has a lot of unique features that differentiate it from other common types of rashes. If the patients do not have these features, then it is very unlikely they have urticaria. The first of which is that hives are itchy as opposed to being painful. The classic description is something called a wheal and flare, which just refers to an erythematous raised lesion that has a central or pale clearing, and usually an erythematous flare or surrounding of that central clearing. Although oftentimes it can be just erythematous throughout. The papules or raised lesions can coalesce into larger plaques like you see in the image on the right. But very unique to this rash is that the individual lesions last for a very short amount of time. So hives are transient. The definition states that they can actually last for up to 24 to 48 hours, but in reality, these patients will report that the individual lesions last for less than a few hours typically. And usually I'll ask patients that if they could imagine taking a marker and circling that part of the rash within a day, is that rash in the same area or has it moved? Because hives by nature are migratory. And then also when hives resolve, there's no bruising or pigment change to the skin. The skin looks back to normal, except for maybe some excoriations from scratching that area. If it doesn't fit this, unlikely to be hives. In terms of how the hives may look, important to recognize that in different skin tones, you'll have different appearance of hives. And oftentimes in darker skin tones, you'll lose the erythematous perspective and it might just look more like the pale lesion, like you see on image B. And then oftentimes when we talk about hives, we also talk about angioedema or swelling. This is non-pitting. It's not gravity dependent. It tends to be asymmetric, so different from edema that you would see from heart failure or chronic kidney or liver disease. Let's start with thinking about a case, and then we're going to use this framework to talk about the condition and how we would approach it. So in this case, we have a 45-year-old female with 2 weeks of an itchy red rash. She's miserable. She's missing time at work because of the rash. And every allergist's worst nightmare, she's treating the rash with Benadryl. She actually goes to the emergency department because of how severe her symptoms are, and they're wondering if maybe she's having an anaphylactic reaction, so they give her epinephrine. That's not the wrong thing to do. That's absolutely okay. And then she's discharged home with an epinephrine autoinjector because they can't figure out what the culprit is. And she's referred to allergy to hopefully find a trigger. So when we're presented with this question of urticaria, there's a few easy ways to break it down that will really narrow your differential. The first question again is this actually urticaria? And what I mean by that is it itchy? Are the lesions migratory? And when they resolve in typically less than a day, do they leave behind any skin changes at all? If it fits urticaria, then we're going to think about, is the urticaria acute, meaning that it's been happening in a short period of time? This uses less than 6 weeks, but in reality, acute urticaria is typically over the course of a few days, but can be repetitive. And then is it chronic, which means are the hives reoccurring on most days for a period of over 6 weeks? When the hives are acute, we think about our typical allergic triggers, so foods, medications, stings, latex, etc. But when the hives are chronic or happening recurrently for a long period of time, it's actually quite likely that either you will not find an underlying culprit, meaning that it's not actually triggered by an allergy, or that perhaps the hives are what we call inducible or triggered by a physical presence on the skin. So the most common version of that everybody has likely seen is something called dermatographism, where patients scratch their skin and they develop hives where they scratch, but there can be other triggers like heat or cold and so on. The acute urticaria, so hives that have been present for less than 6 weeks in general, often much shorter timeframes than that, they're very common. So almost everybody, if not everybody who practices medicine, will see hives at some point. It's more likely in these cases of acute urticaria that you're going to find a trigger, but still in a lot of cases it remains unknown. So it can be a bit of a task to find the trigger. And in these cases, acute urticaria, because there's more likely to be an allergic trigger, we're also more likely to use skin testing in the allergist office to be able to find a specific trigger for this patient. But we don't bring them in and complete skin testing to everything in hopes that we find a trigger. As Dr. Abrams mentioned earlier, you're very likely to get false positive tests. We complete skin testing if we suspect we know what the trigger might be, or if we want to rule something out specifically. In terms of the causes, I think the easiest way to think about it is acute urticaria can be from an allergic trigger Most of these, but not all of them, are mediated by the IgE or typical allergic antibody, or you can have non-allergic triggers. In children, this is very commonly from infections, and then in both adults and children, it can be from stress. I'll never forget in my first year of university, my roommate was so homesick that they had hives for the first 2 weeks of university. That's a classic case of stress-induced acute urticaria. So obviously in that case, we wouldn't do skin testing, won't find an allergic trigger, but still fits this definition. Just as some proof to the concept here, this is an older study, but gives you the sense that in a younger patient population, so here 1 to 36 months of age, who presented to hospital with acute urticaria, the vast majority either had a confirmed infectious cause or based on their symptoms had a suspected viral illness, more rarely bacterial, but typically in children, we see hives with infections, and it can occur prior to, during, or after the actual infectious symptoms. So something to keep in mind. This is actually a reason why a lot of people might get inappropriately labeled with an allergy, like for example, to an antibiotic, because they happened to have hives with an infection that happened at the same time they were receiving an antibiotic. So something to consider. The ultimate treatment for acute urticaria is going to be identifying and avoiding the trigger. So this is where our allergy testing can potentially help to guide that avoidance. Like I said, there might be non-allergic causes like infection to consider. And then later when we talk about chronic urticaria, we're going to mention about antihistamine use and which antihistamines to use and at which doses to use them. Like I mentioned earlier, in patients who have more long-standing or recurrent hives, they may have something called inducible urticaria, which just refers to the fact that there is a physical trigger that can induce the hives. This is a classic example of cold-induced urticaria, a difficult condition to have right now in Winnipeg. But the idea here is that patients can develop typical hives in response to cold stimulus on the skin. This is a test that we do in the clinic to help confirm that diagnosis, where we'll put something like a cold pack on their skin for 5 minutes. And then usually in the 10 minutes after we remove the ice pack, they'll develop a very typical hive-like or urticaria lesion. The other very common form of this is dermatographism, very, very common. So this is referred to sometimes as the itch that rashes. So patients feel itchy, they scratch their skin, and then in the areas where they've scratched, you get these wheals or hive formations in the areas of friction or trauma. So this is something you can actually also precipitate in the clinic. I typically will use the tip of an otoscope device to scratch the surface of the skin. And then usually within about 10 minutes, you're going to see this typical hive or wheel-like pattern show up in the area you've scratched. More broadly, when we see patients with chronic urticaria, so again, hives that are coming and going, but for a period of greater than 6 weeks, we obviously think about those inducible causes based on history. There might be some other more ominous causes that we have to think about. There'll be some pictures to better exemplify this, but we think about urticarial vasculitis. So this looks like hives, but has some red flag features. Primarily, it's painful instead of itchy. The hives last for more than 48 hours, and when the hives resolve, there's bruising or discoloration. You can also get mastocytosis, which is essentially an overproduction of mast cells from the bone marrow or accumulation of mast cells in a tissue. In children, it can be primarily just cutaneous, where in adults, they tend to have more systemic disease. And this could even be a very aggressive disorder like mast cell leukemia. And then other rare disorders that we see very infrequently, something called Schnitzler syndrome, which is chronic hives in a patient with monoclonal gammopathy. And then there are some genetic conditions where patients have familial cold urticaria, which typically starts early in life and has some other systemic symptoms like fever and arthralgia. So The idea here is that if somebody's having recurrent hives, you're going to look for some red flag features, namely, is it behaving like typical hives, and are there any other
Thank you. You can begin again.
Thanks, everybody, for being patient while they were sorting out the tech issues. Dr. Zaborniak will continue.
Yeah, apologies, everybody, but hopefully smooth running from here on out. So yeah, I think this is the most important part of today. So hopefully everything will just continue from here on out. So this is the condition I think is probably most misunderstood and get a lot of referrals for it. And chronic spontaneous urticaria falls obviously into the category of chronic urticaria where patients are getting recurrent hives for a period of greater than 6 weeks. It's relatively common, up to 5% of the general population, depending on which population you look at, but much more common in adults, tends to start or be most commonly found in somebody's 20s to up to age 40. And typically our patients are female as opposed to male. External triggers in this case cannot be identified from the standpoint of an external allergen, which gives it the name spontaneous. So the definition is that there really is no rhyme or reason as to why they get hives. And like a lot of these hiving conditions, it can coexist with angioedema. And the reasoning there is that angioedema is essentially the same process as a hive, but at a deeper level of the skin tissue. So hives and angioedema typically go hand in hand. The theory as to what causes the condition falls into what we would call either an autoallergic or autoimmune condition. And the leading theories is that about 50% of patients either have allergic antibodies that recognize a self-antigen, so not an external allergen, but actually a self-protein, or the patient might actually have autoimmune antibodies, so IgG antibodies, that recognize their own IgE or recognize IgE receptors on the surface of our allergy cells. So again, not being triggered by something external like food or medication, but this is an internal process. The best way to diagnose this condition is the history. So you talk to the patient about how often they have symptoms. Do the symptoms fit that typical description of urticaria? And what is their pattern of reoccurrence? Typically, they may give you a history where their hives are happening overnight or first thing in the morning when they're several hours removed from any kind of exposure, which gives you the clue that there likely is not anything specifically triggering the symptom. Obviously, on physical examination, if you can see a typical hive-like lesion, that's very helpful. Or if you want to do types of testing that we would do in the clinic, just try to stimulate cold urticaria or dermatographism. These are things that can help define what's triggering their urticaria. In terms of actual testing, because there is no allergic trigger, we typically will not do allergy testing for these patients. As Dr. Abrams mentioned earlier, high false positive rate when we don't know what we're looking for, and it does not have a role in this condition. You can do some basic blood testing. Some societies recommend doing CBCs and CRPs, but the Choosing Wisely campaign has actually recommended that there is no required blood work for patients who fit the criteria for chronic spontaneous urticaria. More so blood work if they have red flag features or systemic features that make you question the diagnosis. In terms of how to treat it, the two blue boxes at the top of this page are really what can be done in the family doctor's office. And then when patients are not responding to those therapies, that's when a referral to an allergist to consider additional therapies should be completed. The treatment is starting a second generation, so non-sedating, non-diphenhydramine antihistamine. And typically these patients who have chronic or recurrent hives benefit from having this treatment daily, not just when they have the symptoms, but daily to also help prevent symptoms. If they're not responding to the typical over-the-counter dosing, there actually is room to increase them up to 4 times what the box recommends. And this is well studied to be safe, assuming the patient has normal renal function. This graph includes on the far right side a mention about using corticosteroids. I would caution you to try to avoid the use of things like prednisone for chronic urticaria, because I could almost guarantee you that when you stop the corticosteroid, their hives are going to flare significantly. You're much better served being aggressive with high-dose antihistamines and then calling the on-call allergist or referring to allergy to talk about additional options that can be added on to try to avoid steroid use. The antihistamines that are preferred or available to us are listed here with both the generic and the brand name. In my opinion, there really isn't a large difference between the available over-the-counter antihistamines. So typically, whatever a patient is able to afford is the best option. So knowing the antihistamine names, patients may choose to pick one based on affordability. Patients may have a personal preference of what they feel is best for them, but in general, all relatively similar. And if your patients have private coverage, then they may be able to get coverage for either blastine, rupatadine, or cetirizine. So something to consider to help control the cost of the therapy. Like I mentioned earlier, the thing to keep in mind here is that once you start using the over-the-counter or typical dosing, especially in adults, you have a lot of room to be more aggressive and move up on the dosing up to a 4-fold dose of the over-the-counter recommendation. And this is often needed in these patients. They often will not have a complete remission or response with just typical dosing. So you shouldn't be worried about increasing the antihistamine dose. And like I said, you could reassure patients that it's well studied to be safe at the higher doses, even for long-term usage, assuming that they have normal renal function. You'll notice here as well, I should say as well, that you'll notice I'm not saying to use Benadryl because I do not want you to use Benadryl. In my opinion, there really is no indication for ever using Benadryl. And this is a great example of a condition where you should not be recommending Benadryl. The therapies that we consider once a patient has not responded to antihistamines are usually in the realm of biologics or immune suppressing therapies. The most common treatment that you might see patients on is called omalizumab, which is a monoclonal antibody to IgE. And we typically start it at 300 milligrams every 4 weeks. And this has the ability to achieve complete symptom resolution in about 3/4 of patients or so. But this is something that's guided by typically an allergist. So let's go back to our patient. So 45 years old, she was having 2 weeks of itchy red rash. She was seen in the emergency department and they referred her to allergy to try to find a trigger. By the time she's been seen in the clinic, she's now had 8 weeks of urticaria. So she now fits that definition of chronic urticaria, where we're much less likely to find an allergic trigger. And she was started on 20 milligrams, so kind of twice the over-the-counter dosing of cetirizine once a day. And for her, it achieved a good control of her symptoms. So when should these patients be referred? If you're unclear if the urticaria is behaving like typical urticaria, that's a good reason. If you're wanting to try to find a trigger for their hives, especially in these patients who are having hives for less than 6 weeks, so acute urticaria, or if you suspect somebody has chronic urticaria, but they're not responding to the up titration of their antihistamine, you can refer them. And these are the patients where we consider other therapies like omalizumab. So let's shift gears a little bit, because these patients can also have angioedema. But if patients present with just angioedema, then there are some other special considerations that we need to make. Again, angioedema, it's non-pitting, it is not gravity dependent, and it's typically asymmetric. So in this case, 28-year-old male referred for a possible food allergy. They're having recurrent episodes of swelling to their hands without any clear explanation. when you get their history, they've actually had multiple emergency department visits for abdominal pain. They ended up getting an appendectomy 2 years ago, but the abdominal symptoms continued, and they actually even had a laparoscopy about a year ago, which was inconclusive. On history, their hand swelling is asymmetric. You thought maybe it could be relating to an arthritis, so started them on NSAID medications without any benefit. And on one episode, their hand swelling was relating to eating a peanut about 2 hours prior. So they were also labeled as potentially having a peanut allergy. So lots of different moving pieces here trying to explain the symptoms. Knowing that history, we can think about what would be a good initial blood test to do to screen for causes of angioedema in this patient. So I'll just give a few seconds to think about that. And it'll make a lot more sense in retrospect. So we'll just keep this question in mind, and we'll go through the case and answer it as we go along. So again, angioedema is essentially the same process in a lot of cases as hives, but at a deeper level of the skin surface, although there can be different causes of angioedema in terms of the underlying mediator. Patients can present with pain due to the extent of the swelling, or in some cases, the swelling can be itchy, like a typical allergic symptom. And there's a lot of different common areas of involvement. We think the most concerning area typically is lips, tongue, or airway. Can involve other areas of the face, especially periorbital. And then we see it also in hands, feet, genitals, and in some cases in the abdomen as well. There's really two main mechanisms to think about when you see angioedema, and this will really differ how we diagnose it, but also more importantly, how we treat it. Most commonly when we see angioedema, it's mediated by histamine. So we think about this as kind of being allergic angioedema. A lot of times it makes it easier because it's associated with hives, which are also obviously mediated by histamine. This is our typical things like allergic reactions to something like a food or a drug. Just like we talked about in urticaria, can be precipitated by an underlying infection, especially in children. And then there's some other things to think about, like NSAID use, including aspirin. And then this can also fit into that picture of chronic spontaneous urticaria, which we talked about, where people can also get angioedema in that condition too. The other category is mediated by bradykinin, which is not an allergic mediator. It has nothing to do with our allergy cells. These patients don't have hives with their angioedema. That's typically the easy way to differentiate it. Especially in adults or older adults, a lot of times you might think about ACE inhibitors. There's also DPP4 inhibitors used for diabetes, or the gliptin medications that are also associated with it. Although it's caused by a medication, the mechanism is not allergic. And this makes sense when you see these patients because they can actually have angioedema months beyond taking the medication. So they could have been on an ACE inhibitor for many months or even years before they get angioedema, which is very different from allergy. And then the thing that's a bit unique to this category is what's typically referred to as hereditary angioedema, which is deficiency of something known as C1 esterase inhibitor. So hereditary angioedema, it's a genetic or hereditary condition that's inherited in an autosomal dominant fashion. Typically, these patients either cannot produce this part of our complement cascade known as the C1 esterase inhibitor, or they might produce that, but it's dysfunctional. And our testing is essentially aimed at trying to determine if one of those two things is happening. It results from an underlying mutation in C1 esterase inhibitor gene, but about 25% of cases are presenting de novo or spontaneous, meaning that they might not actually have that easy family history. But if they have the family history of a family member with recurrent unexplained swelling, and they have swelling, this is certainly going to be on the top of your differential. Just like in the case that we started with here, they can get what are known as acute abdominal attacks. So they present with unexplained abdominal pain. If they happen to get imaging, you might actually see things like bowel wall edema that's depicted in the CT scan result here. So this could be an explanation for patients with recurrent unexplained abdominal pain, something to keep on your differential for those challenging patients. The most concerning area of involvement is the upper airway. And prior to a lot of the modern therapies, patients would actually have a relatively high risk of fatality or mortality from asphyxiation. But thankfully, we have a lot more access to acute treatments now. The image on the right is just showing endoscopy view of the vocal fold area going down into the airway, and then the lower image being how dramatically impacted it can be from swelling. So this is like an emergent situation and potentially somebody who needs intubation or cricothyrotomy. So this is potentially life-threatening. The clinical presentation that can help identify it is typically this recurrent non-itchy angioedema that's not associated with hives. A lot of patients will have their first attacks around the time of puberty. However, it's typically a big delay in diagnosis because it's under-recognized. The episodes of swelling can often be triggered by something. We think about trauma or stress, infection, medications like ACE inhibitors or exogenous estrogen. And then, like I said, a lot of the cases start around the time of puberty. So these are not allergic triggers, but they are associated with having these acute attacks. And unlike typical allergic or histamine angioedema, this angioedema is somewhat slow to start and slow to go away. So it tends to slowly progress over several hours as opposed to starting and peaking very quickly. And then it takes several days to resolve, which is different from our typical histamine or allergic angioedema. The frequency of these events can be extremely variable. Some people have a few events over the course of their life, or others can have weekly events. So extremely variable presentations. And when should you do screening to see if somebody may have this? So, the classic story, recurrent swelling without hives. In somebody who you see in your clinic who has recurrent episodes of unexplained abdominal pain, something else to consider screening for. If they've had even just a single episode of airway angioedema that was unexplained, or of course, if they have a family history of angioedema, especially if they have a known family member with hereditary angioedema. The way that you can do this is through some readily available blood work. So in Manitoba, we can look at a C4 level, which is a really excellent screening test. In hereditary angioedema, in about 98% of patients at baseline, their C4 level is going to be low. And then on the provincial immunology requisition, you also have access to doing C1 esterase inhibitor level. There are other assays that are typically done by allergists. Theoretically, you can ask the province to apply for this testing, but it requires the test to be sent away. So typically, it's done by an allergist who's pre-approved to do it, which is essentially an assay that looks at the function of that C1 esterase inhibitor. And there's some other testing. There's versions of this that are acquired, usually with autoimmune disease or malignancy later in life. And we can check for something called a C1q level that will be low in those cases, but normal in a typical hereditary angioedema case. And then in some cases, we might even do genetic screening as well to try to find that initial genetic change that results in this condition. Not super important to memorize this part, but the main idea being that the most common cause of hereditary angioedema is known as type 1 hereditary angioedema. Those patients have a low C4 level and a low C1 esterase inhibitor level. And because that level is low, their function is also low. Less likely, there's also a population that's known as HAE type 2, where they actually have a normal level of C1 esterase inhibitor, but their function is low. But they also have a low C4 level, which means that is a really great screening test. And then I won't get into it, but there's kind of this Pandora's box condition known as hereditary angioedema with normal C1 esterase inhibitor. So we won't kind of delve into that today. Like I mentioned, the landscape for treatments for HAE is rapidly evolving, and it's a great thing for patients because they now have access to therapies even at home, not for the purpose of memorizing doses and names here, but Traditionally, we had access to something known as plasma-derived C1 esterase inhibitor. So you're literally just replacing the blood enzyme that this patient is deficient in. The brand name is known as Berinert. And then nowadays, we have access for type 1 and type 2 patients to something known as a Icatibant, which is a bradykinin receptor blocker. The important thing here is that Berinert has to be given intravenously, but a Icatibant can actually be given subcutaneously. So much easier for patients to treat themselves at home if they're having an acute attack of angioedema. And then just some other general considerations that are typically made with the allergist, but something to think about in your practice if you have these patients. If they're going for any kind of invasive procedure, that might act as a trigger for the angioedema. So especially maybe if you're a family doctor who works in a surgical setting as well, or you are also maybe in a rural community and you do anesthesia as well, then if you have a patient with hereditary angioedema, you should talk to their allergist to see if they need to get a preventative treatment before surgery. And typically that's the plasma-derived C1 esterase inhibitor, or the brand name is Berinert, given 1 hour prior to that exposure. And they might also need to have that medication available during the OR and in the post-operative recovery period. And then the big change to the landscape in our world is that there is now, for some patients, an option to prevent symptoms in the long term, or long-term prophylaxis. So this is intended for patients who have more frequent or more severe attacks frequently. And traditionally, we were able to give them that blood product on a preventative basis, but in the last few years now, we have access to a biologic known as lanadelumab, which is given typically every 2 or 4 weeks to prevent angioedema, and is quite successful at doing that. And there's some other treatments on the market now, and there's going to be a lot more in the future to achieve that same goal. So overall, it has a very variable prognosis, but with the access to these new therapies, it's a lot more favorable now. Generally speaking, it's a lifelong condition, so patients are at risk for these episodes throughout the course of their life, but using the appropriate therapies can really help improve quality of life and prevent the acute attacks. And then there's a lot of new therapies that are going to change the landscape for this in the coming years in Canada. So back to our case, this young gentleman that was referred for really unexplained symptoms, abdominal symptoms, and had hand swelling. Their blood work showed a low C4 level, which is that great screening test, and their C1 esterase level was low as well. So this would be diagnostic of type 1 hereditary angioedema. In this case, they got started on that more traditional therapy where they get that blood product given to them on a frequent basis for prophylaxis. And they also have access to this on-demand subcutaneous therapy known as a Icatibant at home to treat acute episodes. And happy ending in this case, no further emergency department visits. So for these patients, when should we refer them to a specialist? Any angioedema is a great reason to refer to an allergist. If you have a patient who has angioedema and they're on an ACE inhibitor, consider stopping the ACE inhibitor until they're assessed by us, or you might consider calling the on-call allergist to see if you should stop their ACE inhibitor. And then anybody who has hereditary angioedema requires quite specialized and multidisciplinary care. So those patients need to have an allergist. In summary, going back over everything we've talked about, just keep in mind that acute urticaria, so urticaria happening for less than 6 weeks of duration overall, is much more likely to have an allergic trigger for which our testing can be quite helpful. But in patients with chronic urticaria, so hives coming and going over a period of greater than 6 weeks, much less likely to be allergic, much more likely to be spontaneous or an internal autoimmune or autoallergic process. The initial management of urticaria is using those non-sedating antihistamines, and you can up titrate or up dose them to up to 4-fold dosing from the over-the-counter suggestion. And then in patients with hereditary angioedema, you want to consider screening for that condition if their patients are having recurrent swelling without hives, if they're having unexplained abdominal attacks of pain, if they have unexplained laryngeal swelling, or of course, if they have a known family history of angioedema. So thanks for paying attention and being here, and apologies again for the technical difficulties, but happy to answer questions in the time that we have.
So there's a
Yeah, I could start.
yeah,
Sorry, Lana, yeah.
do the questions. Okay.
Yeah. So the first one, I love that question. Yeah. So actually, like the Canadian Society of Allergy and Clinical Immunology has for many years been lobbying and writing position statements to have diphenhydramine or Benadryl banned from over-the-counter sales. But we have been unsuccessful. So that's the importance of these types of education sessions, is to help educate that really no indication for Benadryl. And I even mean that in the setting of emergency department anaphylaxis. That's where IM epinephrine should be used. And then for conditions like urticaria, if you're just trying to treat hives, there are much more effective antihistamines that are non-sedating and safer for patients. So no, in my mind, really no indication for Benadryl. The second question, so common presentations are young children with urticarial rash with triggers seemingly like grass or something else. Do they need confirmation or just PRN antihistamines? Yeah, this can be interesting. Like some of these kids actually have dermatographism. So it's not the grass as an allergen, but it's the scratching of the grass on the skin that causes the hives. Versus, kids with pollen allergy, the grass pollen theoretically could get hives from contact as well. Yeah, if they respond well to using antihistamines and you don't have concerns about other systemic features or symptoms beyond that, then it's very reasonable to not have to confirm that trigger. But if they're not responding to the typical treatment or you have any concerns otherwise, then certainly we could confirm that. And then the third question I see here is, are these patients at higher risk of associated adverse effect of angioedema with ACE inhibitors? Yeah, so if you have somebody with hereditary angioedema and they have an indication for using something like an ACE inhibitor, that is a question that you should ask to the allergist. Typically, unless there is a big mortality benefit in their, let's say, cardiac or renal condition from using that medication, we're typically going to avoid medications that put them at a higher risk of flaring or exacerbating their angioedema. So good question, and should be run by the allergist or immunologist for patients with hereditary angioedema for sure.
So we have a couple more minutes, so we'll wait to see if there's any more questions, and then we'll move on to the last presentation.
Okay, so yeah, for angioedema in the airway, epi won't work. So it totally depends on the mechanism, right? So if it's a histamine-mediated angioedema, then epinephrine will work. And if somebody comes into your local urgent care or emergency, et cetera, and they have airway angioedema, you absolutely should give them epinephrine. That's the first line therapy. If they have bradykinin-mediated angioedema, then epinephrine, steroids, antihistamines will not touch that swelling. That's typically the case. So these patients come to emerge, the emergency doctor thinks they're having anaphylaxis, but they don't respond to epinephrine and other allergy therapies. So typically that's when we get a call to try to approve the use of some of these medications used for bradykinin angioedema. And then another question here, still a use for ranitidine with cetirizine. Yeah, it's an interesting question. In chronic urticaria, sometimes we use ranitidine as an adjunctive therapy with cetirizine. Evidence for that is mixed and not very strong, but typically we use that as a bridge to other therapies or as another option before we get to another systemic type therapy. So it can be used. And then about dental management in HAE patients, I avoid procedural sedation for invasive oral procedures, and I rely on their self-reporting for early symptoms of attack. But do you think the stress reduction effect of sedation outweighs this? Yeah, I mean, I because of how effective the pre-treatment can be, I wouldn't alter somebody's surgical care from the point of angioedema. Like I wouldn't prevent them from getting sedation or certain surgery procedures, but it's just managing the risk with appropriate use of pre-treatment. The issue is just that if you don't have the available therapies or if you haven't pre-treated them and they have an angioedema, especially airway attack in the setting where they're at, especially if that's in the community, then that's a nightmare scenario because they're not going to respond to treatments that you likely have on hand, and they're at a high risk of poor outcomes. So in patients going for any kind of invasive oral procedure, I would definitely consider pre-treatment, and I wouldn't be so reliant on self-reporting because by the time they have the symptoms, it might be too late if you don't already have medications available to treat this kind of angioedema. That's a pretty high risk scenario.
Okay, so it looks like that's the end of the questions. Thank you so much, Dr. Zaborniak, for coming today.
Yeah, well, my pleasure to introduce yourself. So Dr. Lana Rosenfield. So Dr. Rosenfield obtained your undergraduate Bachelor of Science honors in genetics degree and Doctor of Medicine from the University of Manitoba. Following the completion of her medical degree, Dr. Rosenfield completed an internal medicine residency through the University of Manitoba. And in 2017, she completed her clinical immunology and allergy subspecialty training at McMaster University. She is an assistant professor at the University of Manitoba in the section of allergy and clinical immunology and currently practices at the Winnipeg Clinic. So thanks for being here, Dr. Rosenfield.
Thanks for having me. Hi, everybody. This is the last talk of the day, so hopefully everybody's not too tired. So we're going to be talking about allergic rhinitis today. Again, this is an accredited session from the CSACI Royal College. So what are the learning objectives that we're going to talk about today? So we are going to review the workup and diagnosis of patients with allergic rhinitis. We are going to talk about optimizing non-pharmacological and pharmacological therapy for allergic rhinitis, talk about indications for and the process of initiating allergy and immunotherapy, and when to refer patients with rhinitis to an allergist. So some true or false questions that we'll circle back to at the end. So think about what you think the answer is for each of these. Intranasal steroids are first line for mild persistent rhinitis. Beta blocker use is a contraindication to immunotherapy treatment in rhinitis. Sublingual immunotherapy has more favorable safety profile than subcutaneous immunotherapy. So we'll get to each of these questions throughout the presentation and then review the answers. So first starting with the case, so a 24-year-old female who has symptoms of seasonal rhinitis for the past 8 years, worse mostly at the end of the summer, early fall, currently using over-the-counter antihistamines and no other medical issues. So when talking about rhinitis, of course, there's allergic rhinitis, which we're going to focus on today, but there also are some others. So the allergic rhinitis is going to be your IgE-mediated inflammation on the nasal mucosa. It's an eosinophilic process with Th2 cell infiltration of the nasal lining. And then there's autonomic causes of rhinitis. So this would include vasomotor rhinitis, rhinitis medicamentosa. Hypothyroidism could produce symptoms of rhinitis, hormonal issues, as well as non-allergic rhinitis with eosinophilia syndrome. As we know, frequently infections can cause rhinitis, most commonly viral infections. And then there can also just be idiopathic rhinitis where we never find a specific cause. So when thinking about rhinitis, it actually is quite prevalent in the population and has been found to affect at least 20% of Canadians. A lot of people might say, oh, it's just a runny nose, it's not so bad, but it actually can severely impact people on their sleep, their quality of life, and work and school performance. And this has especially even been found to be a factor in kids who have persistent rhinitis, who have issues with school performance. Many patients that do have rhinitis also report that the symptoms that they have are not fully controlled. And actually, there was a study of over 1,000 Canadians that found that 62% of patients with rhinitis felt that their symptoms were only somewhat or poorly or not controlled at all. So when looking at the pathophysiology of allergic rhinitis, this is the IgE mediated. The IgE antibodies are bound to mast cells, and then when they encounter an allergen that they are specific for, and this would only happen in these sensitized individuals, it will result in cross-linking, and then you end up with mast cell mediated release, such as histamine, leukotrienes. In the early stages, this will lead to arteriolar dilatation, vascular permeability, itch, rhinorrhea, and mucus secretions. And then more later phase, you'll have a more cellular inflammatory response. So there is quite a strong association with allergic rhinitis and asthma. Given that kind of the upper and lower airways are connected, they're very similar in many ways, have very similar linings and cells present in both. We actually even talk about sometimes that allergic rhinitis is a component of a systemic airway disease. There really is a big risk factor for developing asthma in patients that already have rhinitis and so forth. Asthma has been found in 15 to 38% of patients with allergic rhinitis. And we know that having allergic provocation in the upper airway, so if you're having active allergic rhinitis, that this actually may lead to worsening lower airway inflammation. So sometimes we like to think that actually treating the allergic rhinitis can actually help the asthma a bit too. So when classifying allergic rhinitis, in the past and historically, a lot of times it used to be done by seasonal versus perennial, but now because of people living in locations that might have seasonal allergens year-round, and we think that it's better to approach it more with the intermittent or persistent. So with intermittent, it's going to be symptoms less than 4 days per week, or less than 4 consecutive weeks. And with persistent, it's going to be more than 4 days per week or more than 4 consecutive weeks. Then we look at to see how severe are the patient's symptoms. So more mild, it really is not going to be affecting your sleep, daily activities, work or school, and really no significant bothersome symptoms. Where moderate severe, there is going to be more sleep disturbances, impairment in regular activities, and symptoms that are bothersome for the patient. So something that also exists is something we call localized rhinitis. So this is when there's a localized rhinitis just to the nose. So with these patients, we actually won't find allergies when we do allergy testing because it is localized to the nose. Symptoms are very similar to allergic rhinitis, but we'll never actually be able to prove the specific allergen based on our routine testing that we do. There are special nasal allergen challenges that can be done, but this is really only done on a research basis and isn't something done in the general population. So how do we diagnose allergic rhinitis? So like many of the things we talked about today, history is going to be very important. So classic symptoms that we encounter will be nasal congestion, nasal itch, rhinorrhea, sneezing, and there often is allergic conjunctivitis that is associated with redness of the eyes, tearing, and itchy eyes as well. So we also want to find out about potential triggers. So it's important to ask, is this happening year round, certain times of the year? And this can be a different factor for people living in different populations. So certain allergens that are prevalent in Manitoba might be present in different areas of the country at different times of the year just because of the weather patterns. across the country. And actually, some of this has even been changing, even with climate change as well. We always want to find out about the home environment. Are there any pets? Is there carpet, humidity? And then work or school environments can also be a factor as well. For example, is somebody a farmer working with certain grains that can have grain pollen triggering their rhinitis? Are they a veterinarian? All of these things can be important on the history. And then what medications patients are using. Certain medications and certain types of drug use can also be triggers. Something we're seeing more frequently now actually is cannabis allergy as well, and it is something we can test for. And then we also want to ask for different comorbidities that we frequently see with rhinitis. So this would be like asthma, eczema, nasal polyps, and sleep apnea. And there is a known association with family history of having ATP in the family. So finding out if anybody else in the family has a history of ATP. So we also, like you talked about, want to find out how severe the symptoms are. So finding out how it affects the patient on a daily basis, and also want to find out what treatments they've been on, both prescription, over the counter, and how long they use those therapies. Because some of the therapies that we do use for allergic rhinitis do need to be used for a bit more longer period of time to actually be optimally effective. So finding out how long they've actually used these therapies is important. We also want to kind of talk about some of those other areas of rhinitis that isn't allergic that might be at play. So vasomotor rhinitis, which may be more affected by temperature changes, irritants, or odors. Gustatory rhinitis, which is when you have rhinorrhea after eating, or if there's nasal polyposis, a lot of times this will be a decreased or no sense of smell at all, seeing if the patient has any sensitivity to NSAIDs or history of asthma as well, because then you can see that with AERD. So when looking on the physical exam, just kind of looking at the patient general appearance, something we typically do is say, do they have more of a nasal voice when they're talking? Are they rubbing their nose a lot? Are they mouth breathing? Are they sniffling? Looking for transverse nasal crease or allergic shiners, which are those dark circles under the eye, which can be associated with nasal congestion. We always want to make sure we look in the nose. With allergic rhinitis, it actually is more of a pale mucosa that you expect. We also look for swollen turbinates or even bridging of the turbinates as well. You also want to look for other structural issues, especially if patients are having unilateral symptoms. Is there a septal deviation? Is there any obstruction in the nose? Are there polyps? To be able to think of other things on the differential. When looking at the oropharynx, you actually sometimes can see mucus dripping down, which can be a factor with postnasal drip that can come with allergic rhinitis, or cobblestoning to the tissue at the back of the throat. You want to always palpate the sinuses to see if there's any tenderness, and also assess for comorbidity. So looking at the skin, seeing if there's any evidence of atopic dermatitis, and doing a respiratory exam, looking for any wheeze or signs of asthma. So really the main thing that we use for testing is the allergy skin prick testing. We do choose the relevant allergens for the patient's environment, and the testing panel that we test for in Manitoba is going to be different than a testing panel that's done in BC or done in Arizona or done in Florida, because the allergens in the environment are different in all of these locations. And every allergist kind of picks the allergens that they choose to test. And likely if you go to 3 different allergy clinics, even within Winnipeg, there might be little small differences between the panels. Patients do need to be off of antihistamines prior to testing, and we do use positive and negative control. The positive control is histamine itself. When we do this testing, most of the time it's done on the forearm, sometimes on the back, depending on the situation. Most of the time it will be a small bit of liquid that's put on the arm, and then it's just a small little prick that's done usually with like a little plastic pricking device, as you can see in that picture here. And sometimes it's done with a metal lancet. It takes about 15 minutes, and then we see the results right after. There is an alternative that we can do. So allergen and serum specific IgE test. We are very fortunate in Manitoba. These are free for our patients. In Ontario, it is not and can be quite expensive, especially if you have to do a whole panel of inhalant allergens. We will use these for people that we can't do skin testing on, such as those who can't stop antihistamines for other conditions, or even if these symptoms are so severe. If patients have significant skin disease where you're not going to be able to do it. If people are dermographic, like Karver was talking about, every test sometimes will look positive. So you can't actually interpret the test because this prick itself will cause a hive. And sometimes this will be done in areas where specialists weren't available. During the pandemic, this was something that was done a lot more frequently to try and prevent in-person appointments. And so it is an alternative that we can do, but really the one that we do the most and is the best test is the skin test. This is less sensitive and it's more expensive for the system, but for our patients in Manitoba, both of these tests are actually free. So then we're going to talk a bit about management. So this is a newer algorithm that was put out by a recently published Canadian practice parameter. And it kind of starts with, if you have the patient that's suspected with rhinitis, you're going to do your diagnostic testing, so either skin prick or specific IgE. And then once you've confirmed allergic rhinitis, there's multiple treatment options for medical therapy, going from the darker blue, which is the most efficacious, to the lighter blue, which is the least, and then talking about allergy and immunotherapy, which we'll talk about further, that can be done at any point after the diagnosis has been made. So one of the most important things to do once we've made the diagnosis of allergic rhinitis is figure out which allergen it is and talk to patients about avoidance measures. So certain things are going to be very hard to avoid and some other things might be a little bit easier. So for dust mite allergy, we really tried to talk to patients about washing their sheets once a week in hot water, putting dust mite covers on their pillows and mattress, keeping humidity in the home between 30 and 40%, making sure there's not too many surfaces in the bedroom, are all things that you can do to decrease your exposure to dust mite. Because unlike what a lot of patients think, which is like they're allergic to dust in the environment, it actually is the dust mite that's in pillows and mattresses that they're exposed to. And a lot of these patients will actually have a lot more symptoms kind of throughout the night and in the morning because that's when they're exposed to the dust mite. But a lot of times I'll even tell people, you do all these things, you do all the dust mite measures, they're still going to have some exposure. They're still likely will have some symptoms, but it definitely can help. For pollen and outdoor mold exposures, I kind of talk to people about watching the Weather Network. They actually have pollen counts on a daily basis where you can monitor them, keeping your windows closed during the pollen season, using air conditioning as a filter if you have air conditioning, changing your clothes after being outside during high pollen times are all things that you can do. Then different things like HEPA filters in the house, humidity control when it's more indoor molds. When it comes to animals, unfortunately, a lot of times removal from the home is going to be the suggested course of action when it comes to somebody in the home having symptoms of allergies with a pet in the home. But a lot of times we know this is practical and most people don't want to get rid of their pets. Interestingly, there is actually a cat food that is on the market that actually decreases the protein of cat allergen that the cat produces. So there is some evidence to show that might be helpful, but also trying to keep the pet out of the bedroom, not to have as much contact with the pet, washing your hands after being in contact with the pet, and having HEPA filters in the house can be helpful for that. And then other things can also be irritating. So if there's smoke exposure in the house, something you always want to try and avoid. So antihistamines is something that's used a lot. This, again, something that's been brought up multiple times today. Avoid first-generation antihistamines. And this goes beyond the diphenhydramine Benadryl, but even hydroxyzine or other over-the-counter first-generation antihistamines are going to be ones we do not recommend patients use because of the negative side effects that are associated, and then sometimes they actually don't work as well. I have a lot of patients that will tell me, I need to take that Benadryl at night because it makes my symptom, because then I can sleep because I can't sleep without it. The issue is that also while it does make people sleepy, because it can actually even just generic diphenhydramine is generic over-the-counter sleeping pills. It actually alters the REM sleep and doesn't give you a good of a restorative sleep. So I do really try to counsel patients to not use first-generation antihistamines orally ever. And unfortunately, we have not been able to, like Dr. Zaborniak mentioned, properly lobby for it to get to be behind the counter. The second generation oral antihistamines are the ones we recommend. These will reduce your sneezing, your itch, your rhinorrhea. They have a little bit less impact on the congestion symptoms, but it is something we find very helpful for our patients. So similar to the last presentation, these are the antihistamines that are available in Canada currently. And then really the first line mainstay of treatment that we talk about with allergic rhinitis is going to be that intranasal corticosteroid. This is the first line of patients with mild, persistent, or moderate severe symptoms. It really should be used on a regular basis. They talk about the peak effect taking days. It can even be longer than that. I usually want patients to at least try a few weeks to a month or two on it on a consistent basis to really know if it's optimally effective. This will reduce some lower airway symptoms in patients with concurrent asthma, like I talked about before. And technique is a real important part of these nasal steroids, people using them properly. So different things I talk about with patients is trying not to use hit the inside wall of the nose, trying to target it towards more the outer edge of the eye or to the ear, using the right hand for the left nostril, the left hand for the right nostril, making sure patients don't do a big sniff at the time of spraying it, because then it's just all going to go to the back of the throat, are all different techniques that I talk to patients about for trying to have it be more effective, but also trying to reduce the side effects, because it can cause a lot of irritation to the septum of the nose if they just keep on hitting it to the nasal septum. So there have been various studies and meta-analysis that have shown that intranasal steroids are superior to antihistamines as well as leukotriene receptor antagonists in controlling the symptoms of allergic rhinitis, including both nasal congestion and rhinorrhea. So this is showing the intranasal steroid versus the antihistamine, and this is showing the leukotriene receptor antagonist versus the nasal steroid. So what nasal steroids do we have available? So there's a lot. The ones that are available over the counter are the triamcinolone nasacort and the fluticasone propionate flonase. The fluticasone furoate Avamys is available in the US over the counter, known as Flonase Sensimist. All the others are require a prescription to be used. So there are a couple newer nasal sprays that are out there that are a combination of a nasal steroid antihistamine. So this includes fluticasone azolastine, which is 1 spray per nostril twice a day, and then olopatadine mometasone, which is 2 sprays per nostril twice daily. The olopatadine mometasone is a bit cheaper than the fluticasone azolastine, even though it is the extra sprays that is accounted into the decrease in price. As well, supposedly has less of a aftertaste side effect, which the fluticasone azolastine can have. But both are found to be more effective than their individual components. So we'll go back to that treatment algorithm later, but the most effective treatment for allergic rhinitis is the combination nasal steroid antihistamine. And really, we consider these when the monotherapy with either the antihistamine or the nasal steroid are not working. It is for ages 12 and older, and is something we've been starting to use a lot more. And it also helps ocular symptoms as well. The leukotriene receptor antagonists, so these were originally used mostly for asthma, but there has been evidence to show that they do help with allergic rhinitis. We talk about considering adding these when the oral antihistamine nasal steroids or the combinations are not tolerated or not working as optimally as we would hope. It is inferior to the nasal steroids, even when it's combined with an antihistamine. But it is important to know that there is potential neuropsychiatric side effects of these medications. There is a black box warning, and this is being looked into further. It was previously, before this black box warning on it, we always talked about kind of nightmares or night terrors in children, but there is some evidence to show now that there are neuropsychiatric side effects in adults as well. So allergen immunotherapy. So this is something great that we have to use because it actually is a disease modifying therapy that actually can produce long-term benefit by using this for, say, 3 to 5 years. So this actually decreases the amount of allergic antibody in the patient towards the specific allergen. We always talked about using this in patients who symptoms are uncontrolled or intolerant or averse to pharmacotherapy. Averse to pharmacotherapy could purely be somebody saying, I don't want to use pharmacotherapy. Someone say, I don't want to use a nose spray, I don't want to use an antihistamine. It really can and should be offered at any point in management once someone's been diagnosed with allergic rhinitis. So just letting them know that option is there if they don't have any contraindications. So it is indicated in patients with allergic rhinitis and conjunctivitis and or allergic asthma who have evidence of a specific IgE to relevant allergens that are causing their symptoms. So there's 2 types. One is the subcutaneous immunotherapy. So this is when people talk about allergy shots. So this is increasing amounts of allergen given on a weekly basis. So it takes about 4 to 6 months to reach a target dose. Some people, I myself sometimes will do 1 or 2 injections per week, which can help decrease that buildup period. Once the patients are at the buildup target dose, they do need to be on it monthly after that. If they stop missing appointments, having reactions, that can extend the period of time. There is, I should say, was a pre-seasonal option for pollens where people can get injections, typically 9 weeks. Sometimes there was a product that was a 4 weeks of injections prior to the season every year for the 3 to 5 years. But unfortunately, most of those pre-seasonal immunotherapy are not being produced anymore. So it's quite difficult to get people on it to start now. But we do see prolonged benefit after people have been on this therapy for 3 to 5 years, because it really is, like I said, disease modifying. It really shifts from a Th2 to a Th1 process in the immune system and decreases the amount of IgE towards the allergen that you are targeting. So these are the allergens that we have evidence for allergic rhinitis, and the ones with check marks are the ones that are standardized in Canada. This does not mean we can't treat other ones, and we do. So anything that we test on our rhinitis panel, we can treat with immunotherapy, because actually the reagents that we use for skin testing is actually the same stuff that we use to create the allergen immunotherapy vials. So there are hundreds of non-standardized extracts that are used. There's a caveat to dog there. It can be difficult to attain therapeutic dose for dog based on the extracts available in Canada. There are some newer dog extracts that are out, and another one that's going to be coming out that have shown to have a bit more efficacy for dog. Because we actually find that a lot of people with symptoms that are very suggestive of allergy to dog will actually likely be negative on skin testing. But there's, like I said, newer reagents out that are helping with that. So there are some reasons that you shouldn't be put on allergy shots. So if you have severe poorly controlled asthma, this is because we are giving you something our patients something they're allergic to, and therefore there is a risk of anaphylaxis from allergen immunotherapy, and you can have worse outcomes of that anaphylaxis if your asthma is not controlled. If you have any medical condition that increase the risk of death with a systemic reaction, in that same theory of uncontrolled asthma, if you're on a beta blocker, because it makes the anaphylaxis a little bit more treatment resistant, and then pregnancy. So if people are already on immunotherapy and they become pregnant, they can stay at their current dose, but we wouldn't start them or continue to increase building them up if they do become pregnant. If they are in the middle of their buildup and they become pregnant, we actually usually will just keep them at the dose that they were on at that time. So adherence is really important. So it can really modify the length of time on therapy and the benefit if patients don't come in at their regular weekly or 4-week intervals once they're on maintenance. And like I said, there is a risk of systemic reaction when doing this therapy, so it is not without risk. More commonly, side effects we see will be itchiness or redness at the site of the injection, and a lot of times that will be improved with pre-treatment or with antihistamines. So this is just a sample of a build-up protocol for subcutaneous immunotherapy. A lot of times we actually ask on you from primary care if you are willing to assist with doing the injections, whether it's too hard for the patient to come to our allergy clinic to get the injections just based on where we're located and where they are in their daily lives, or if there's someone in a community where there is no allergist there. We see a lot of patients from rural or community or cities outside of Winnipeg that we do want to start on immunotherapy. Most of the time, the allergist, I would hope, and what I do is I send a whole handout to the primary care provider or whoever has been willing to take over the immunotherapy shots with the specific build-up protocol that I recommend, as well as a lot of kind of troubleshooting, as well as our contact information, making sure that we're always available to the primary care providers giving these shots if any questions were to arise. And kind of we always give examples of what to do with missed doses or for example, with pollen allergies, sometimes we don't actually build up the pollen during the active pollen season because that could increase the risk of reactions. So some people don't do that. So we would give advice for what to do during the pollen season, things like that. So thank you for those of you who help us get our patients on immunotherapy and give the shots. And just know that any of the allergists that are seeing your patients would be very happy to help guide you if you were willing to do this for your patients that we also see. But there also is another option now, and this is sublingual immunotherapy tablets. So these are little tablets that are put under the tongue. They are only available for 4 allergens. So we have for grass, there's 2 different products for grass. There's ragweed, house dust mite, and birch pollen. These are started on the allergist office, in the allergist office, and then continued on a daily basis at home. Most of them, there's no specific buildup. It's just that one tablet to start. One of the grass tablets does have a 3-day buildup, but only the first day is done in the allergist office. And then they stay on that tablet. So for the dust mite, it's a year-round tablet. For any of the pollens, they generally can be started about 12 to 16 weeks before the pollen season. A lot of times we will then stop at the end of the pollen season and then restart again the 12 to 16 weeks before the next pollen season. Sometimes we do actually stay on the pollen sublingual immunotherapy year-round, whether patients end up going to places throughout the year that they might encounter those allergens in the winter, or there is some evidence to show that there actually might be a little bit more benefit from taking it year-round, specifically with grass. So it's great. There's no injections. So people who have issues with needles and don't want to needle that frequently, it's great. It's definitely much more convenient. They don't have to come into a medical clinic on a weekly basis for 4 to 6 months, which usually I find scares and terrifies a lot of people more than the needle itself. There actually is a better safety profile with sublingual immunotherapy. So systemic reactions are less common than with subcutaneous immunotherapy. Local side effects are more common, like itchiness or swelling in the mouth. Generally, these improve after being on the therapy for a couple of weeks. There are some similar contraindications as there was for subcutaneous. So all the ones for subcutaneous also apply for sublingual, but also anybody who have any oral ulcerations or sores in the mouth, because that can change the amount of absorption than just typical sublingual, as well as anybody who has eosinophilic esophagitis. We wouldn't necessarily use in those patients. So these are the products that we have available. In Manitoba, the oral air is the only one that is on we can get EDS approval for. The other ones are not, but there generally is some support for patients from a paying perspective from the company itself as well. The subcutaneous, is generally covered by most drug plans as well as through pharmacare. So a lot of the times we can get these therapies covered for patients. So this just kind of talks about the treatments that you would use based on the severity and the frequency of patient symptoms. So if they are more mild, intermittent, you can just use an oral antihistamine. If they're having more severe symptoms or more persistent, that's when you would start your nasal steroid. You can also have a nasal or oral antihistamines on top of that, and consider the leukotriene receptor antagonist. And something important to note here that we have that allergen and irritant avoidance measures at all times. Here they have immunotherapy only from like beyond mild intermittent, but as I have here in this newer treatment algorithm, really allergen immunotherapy should be offered and can be offered at any point in time once a patient has been diagnosed with allergic rhinitis. So kind of like what we talked about, that nasal steroid, nasal antihistamine combination sprays are going to be give you the most efficacy. Starting with that or a nasal steroid, generally we will start with the nasal steroid. If that doesn't work, then we do the combination, and then adding on oral antihistamines or leukotriene receptor antagonists, and then having that option for immunotherapy at any point. These are from the Allergic Rhinitis and its impact on asthma, otherwise known as ARIA guidelines. So this talks about kind of in patients who have your seasonal rhinitis, to either use the combination nasal steroid with an oral antihistamine or a nasal steroid alone, but there might not be as much benefit from adding on that oral antihistamine. In patients with year-round symptoms, nasal steroids alone are recommended rather than the combination of the nasal steroid with an oral antihistamine. With seasonal rhinitis, they do suggest the nasal steroid and a nasal antihistamine or the nasal steroid alone. And then in patients with year-round symptoms, suggest either a combination of a nasal steroid with a nasal antihistamine or the nasal antihistamine alone. When talking about the more recent US practice parameters, that really should routinely use monotherapy with nasal steroids first rather than the combination with the oral antihistamine, recommending using nasal steroids over the leukotriene receptor antagonist. And for patients with moderate to severe symptoms, can recommend that combination of nasal steroid and intranasal antihistamine. So when do you refer to a specialist? So if the diagnosis of allergic rhinitis is in question, and really I would say anybody who has symptoms of rhinitis, I think it's worthwhile at any point that they should have allergen inhalant panel done to see if there is anything that's triggering them, whether or not it can help with avoidance measures or being able to offer immunotherapy. So when you don't know about the culprit allergen, refer then. If the patient doesn't have great response to nasal steroid or whatever therapy they're on, come to see us then, or if they want to consider disease modifying therapy. So also something to consider now too, especially if patients maybe that you've been seeing for a long time that have nasal polyps, there are some newer biological options available. This is kind of outside of rhinitis, but we wanted to make sure people were aware of that. If patients have issues with chronic rhinosinusitis with apolyposis, that if they were just more on the topical steroid therapy, that really there are some newer agents out there if patients are having persistent symptoms, that we can always look into biologic options now that have been really helpful in this patient population. So going back to the case, so a 24-year-old female with symptoms of seasonal rhinitis for the past 8 years, more bothersome in August and September, interferes with the work and sleep, and had no other medical issues and just used over it. This means, what would you do? So the exam was normal, and then skin prick testing was done as positive to ragweed. We are starting to see a little bit more ragweed in Manitoba, something more commonly seen in other areas of the country though. And negative to all the other aeroallergens tested, which is a bit of an infrequent thing that we see. Most of the time when we see people positive to allergens, they have multiple ones, but this one was just monosensitized. So what would you do? So we would always talk about allergen avoidance, keeping the windows closed during the times of the year where that pollen is high, and kind of watch the pollen counts to see when they are high in the area that they are in. would start with first-line intranasal corticosteroid and using it during the relevant season. Usually what I'll tell patients, if they really do only have symptoms during a particular season every year, is I tell them to start the nasal steroid a few weeks before the pollen season that they anticipate. So the nasal steroid will be optimally effective by the time that pollen's there. They can always use non-sedating second-generation antihistamines, making sure not to use those first-generation antihistamines. That's, I think, the key point of the day. Don't use first-generation antihistamines. And can always consider the leukotriene receptor antagonist, and then immunotherapy is always an option. Using the subcutaneous route, either giving them year-round. There actually used to be a really great ragweed shot that was just 4 shots before the season, but it's been very hard to get over the last number of years. And then potentially that 9-week before the season option. And then there is that sublingual immunotherapy option for the tablet for ragweed that we would start about 12 weeks before the pollen season. So going back to those questions that we talked about at the beginning, intranasal steroids are first line for mild persistent rhinitis, true or false? I hope everyone now knows that this is true. The nasal steroids are your first line therapy for your persistent rhinitis. Beta blocker use is a contraindication in immunotherapy for the treatment of rhinitis. This is also true because this can have an effect on treatment of systemic reactions if this were to occur from immunotherapy. And then sublingual immunotherapy has more favorable safety profile than subcutaneous immunotherapy. Again, yes, this one is also true. There is less systemic reactions from sublingual immunotherapy than subcutaneous immunotherapy. So true, true, and true. So some key take-home messages. Allergic rhinitis significantly affects patients' quality of life. Allergy skin testing are helpful to confirm the diagnosis and to help guide therapy. Intranasal corticosteroids are the mainstay of treatment for most patients with allergic rhinitis. And allergy and immunotherapy should be considered for patients if pharmacotherapy is not sufficient or tolerated. But really, I think, and what we're now saying is that it really should be potentially offered in any patient with symptomatic allergic rhinitis, as long as they don't have contraindications. So thank you very much for listening. Any questions? So the first question here, can anyone order allergen-specific IgE blood tests? No. In Manitoba, it has to be done by an allergist. And typically we don't start with specific IgE blood tests. We do start with the skin testing. So it's always best to refer to the allergist to get that skin testing done first. And then if we feel that the specific IgE needs to be done, whether we feel that there's an issue with the tests or we want to look into something that we might not have access to doing skin testing on, then we would be able to order that test for you. And I really want one thing I want to make sure that all of you from primary care are aware of. We don't mind seeing these patients with rhinitis. Don't think that you're burning us by sending us a bunch of rhinitis patients. We're very happy to see patients with rhinitis. This is our bread and butter. We like it. We enjoy it. We feel that all these patients should be given the options of these therapies and to know what they're allergic to. So anybody who has these symptoms, we're very happy to see. So how long do patients need to stay on the allergen immunotherapy? So typically 3 to 5 years. So whether this is just with the tablets that they're on seasonally, you would do that for 3 to 5 seasons. For the injections, it'd be 3 to 5 years of maintenance therapy. There, like anecdotally, there are some patients that do end up staying on it longer, whether they find that their symptoms worsen when stopping. For example, I have a patient that I inherited that had been on pre-seasonal tree immunotherapy and had stopped it for a couple of years and definitely noticed that their symptoms had been worse after stopping. I think they'd been on it for about 5 years or so. And then we've just continued, but unfortunately now that product's no longer available in Canada. So they're going to have to stop it after this year. We have the last before the stock in the country expires. So this question says, if someone is not well controlled on the usual treatments and they opt for, let's say, dust mites, they would do the immunotherapy daily for life and not have to take the nasal steroids. No, they'd actually only have to do the daily immunotherapy with the tablet for 3 to 5 years, and then you have long-term benefit beyond that. A lot of times what I tell patients is it's possible that in 15, 20 years symptoms can come back, but people do have long-term persistent benefit after those 3 to 5 years. There are some studies to show that like only 2 years of immunotherapy, you don't have that long-term benefit so much, but 3 to 5 years, I try and get people to do the full 5 years if I can, to have that long benefit. And hopefully you don't need to take any medical therapy on top of that. And one thing I didn't mention here, but actually dust mite immunotherapy also has shown to have some benefit with atopic dermatitis as well if patients are sensitized. Any other questions either about this presentation, any other allergy questions you might have in general? And like I said, if you have any questions after, don't hesitate to reach out. I, as well as Dr. Colin Barber, are available also on eConsult from the adult allergy side, and I think it's Dr. Abrams that's on the pediatric through eConsult. So we are available if you have any questions on specific patients, but you're not sure about sending a referral, that option is always there. You can do that. We'll just wait a couple more minutes just to make sure there's no further questions, and actually we might be done a little bit early. Thank you everybody for being patient with all the audio-visual issues. And if anybody's interested, we're hoping to do another one of these just from this allergy school slide deck. There are a few more topics as well that we're hoping to do in the future. So if this is something you'd be interested in, please put that on your evaluation. And make sure you complete the evaluations for each lecture as well as the overall evaluation. So this is a bit off topic, but for allergy and immunotherapy can be used for folks with anaphylaxis to bee shrimp. Okay, so these are kind of two different things. So first, we'll talk about the bee or the venom. So yes, so allergy and immunotherapy can be done for venom stings and should be done for venom stings for the most part. So venom immunotherapy is one of the biggest life-saving therapies that we as allergists are able to provide because it actually prevents anaphylaxis or systemic reactions by about 90 to 95% in patients that have had previous systemic reactions. So we do offer it in patients who are positive on testing for venom and who have a history of systemic reactions. If it's a non-systemic reaction, there are some caveats, but for the most part, those people aren't at an increased risk over the general population of having a severe reaction if they're stung again, but there might be some situations where we might in that situation. So anybody who's had a venom sting that's had a reaction, any sort of systemic symptoms, definitely refer those. During the pandemic, we stopped all the inhalant immunotherapy. We did not stop our venom immunotherapy because it is life-saving therapy. For shrimp, that would go more for the oral immunotherapy that Dr. Abrams had talked about. I only see adults, and it's not really done much in adults, but I'm not sure how much they're doing shrimp or shellfish for oral immunotherapy, but I believe it is being done. Interestingly, we do see some people that have an association of allergies with shrimp with dust mite sensitization because they have similar proteins. And sometimes we have found that people's symptoms with shrimp have decreased with allergen immunotherapy, but it's not guaranteed but that's for people that have both. So the shrimp would be more from the oral immunotherapy side from the food, where the bee sting would be the venom immunotherapy shots that we do offer. The buildup is different. The length of therapy is similar, 3 to 5 years. But with the venom immunotherapy, we can actually sometimes extend the interval. So it's not as frequent after they finish their first year of therapy. Okay, so if there aren't any more questions, I want to thank everybody for coming for today. This is the first time we've done this, and hopefully something we'll be able to do again. There are about 20 allergists now, I think, in the province, so feel free to refer to any of us if you need a list or anything. You can also reach out. Because there have been a bit more in the most recent years, there actually, I think a lot of the wait lists have come down a bit because there used to be a big shortage, but now there is more of us. So please feel free to Zoom the consults. And like I said, there's also e-consult available if you're unsure. And hopefully we'll see you guys at the next one of these. So thank you everybody for coming. And please don't forget to fill out the evaluation forms.